Welcome back, everybody. David here again with Med School Boot Camp. So in this next chapter, we're going to talk about vasculitides, and this is going to be a jam-packed chapter with all kinds of conditions, vasculitis conditions. Vasculitis meaning inflammation of the blood vessels that can present in patients. There are going to be a lot of key differentiating features between these pathologies, but they can all show up on test day. So we're going to talk about giant cell arteritis, Takayasu arteritis, thromboangiitis obliterans, Kawasaki disease, polyarteritis nodosa, Behçet's disease, cutaneous small vessel vasculitis, eosinophilic granulomatosis with polyangiitis, granulomatosis with polyangiitis, IgA vasculitis, sometimes also called Henoch-Schönlein purpura, microscopic polyangiitis, and mixed cryoglobulinemia. So as you can see, there is a ton to go over in this chapter. So if you all are ready, then off we go. So in this first video, we're going to talk about giant cell arteritis. Sometimes this is also called giant cell temporal arteritis, and you'll see why in a bit. But first, I just want to give a little context here before we dive into all of the details. What is a vasculitis? A vasculitis is inflammation of the blood vessels. And so we're going to talk about a lot of conditions that can lead to inflammation of the blood vessels. This can decrease vascular flow, lead to ischemia, tissue damage, and a whole variety of symptoms that patients can present with. The key here I want you to focus on as we go through this chapter is what are differentiating features between these conditions. We have a lot of different pathologies to choose from, and there's a lot of overlapping similar conditions, but we really want to focus on how do we distinguish these on test day, because they're going to give us multiple option choices, right? They might give us 4, 5, 6 option choices, 6 different vasculitides, and we need to determine which one is the best answer for that question. So let's start off with giant cell arteritis. Giant cell arteritis is typically going to affect large vessels, although there is some overlap between these conditions where medium vessels can be affected as well. So when we think about the epidemiology here, typically in a classic board style question, this is going to present with a prevalence for females over males in an older patient population, often over 7 years old. This is also often associated with polymyalgia rheumatica in addition to the HLA-DR4 gene. So this is important, right? When we get a clue, we always want to think about what age range are we talking about? Would we see this condition in a 7-year-old? Not super likely in a board style question. This is typically going to be an older patient. It's also good to know this association with polymyalgia rheumatica. And can you remember, what is this condition referring to? Well, if you recall, this condition is typically also seen in older patients. And these patients are going to present with pain in a variety of different areas, including their shoulders, maybe their hips, or their neck, in addition to some morning stiffness. And this is such a key association that approximately 50% of patients who have giant cell arteritis also have this condition as well. So again, be on the lookout for this in a question stem where they give you a presentation of polymyalgia rheumatica, and then they kind of refer it back to this other pathology, which is giant cell arteritis. Now, when we think about the pathophysiology here, pretty important stuff, but I don't want to get too bogged down in the weeds. But in general, this is an overactive response by the body leading to vascular inflammation. So we can have dendritic cell activation, which leads to an increased Th1 response, resulting in monocyte recruitment, macrophage differentiation, and giant cells. And giant cells is an important word here, right? We'll talk about the histopathology in a second, but again, this is called giant cell arteritis, so it's named appropriately and helps us with memorizing these key points. Additionally, with the pathophysiology, these giant cells can then go on to produce cytokines, which lead to acute phase reactants, specifically interleukin-6 and TNF-alpha. And then the production of these acute phase reactants increases metalloproteinases. And remember that these are enzymes that can be useful, but too much of them can lead to increased vascular damage to the surrounding tissues. Now, what happens if we have too much damage to the surrounding tissues? Well, the body is now going to react by increasing the amount of growth factors. These include things like platelet-derived growth factor and VEGF. This can lead to intimal hyperplasia and ultimately decreased vascular blood flow. So just a quick review here, as this is a lot to kind of remember. But the idea is that we have an increased cellular immunity reaction in the body, right? This leads to giant cell formation. Giant cells then create a variety of different substances that can actually lead to tissue damage. What happens? And the body reacts by releasing growth factors that can increase the hyperplasia and vascular blood flow. So let's say we have a vessel, right? And that vessel becomes inflamed over time. And now the body is working to release a bunch of enzymes, and now it's trying to build itself back, the growth factors, and all the time, things get thicker and thicker and thicker, and eventually this can kind of create so much inflammation and so much growth in the vessel itself, it actually cuts off blood flow or decreases the blood flow to different areas in the body. And this is kind of the key takeaway point I want you to think about here. Think about the vessel, think about getting inflamed, and a lot of processes happening that ultimately gets narrower and narrower and narrower, because this is a recurring theme that we're going to see with a lot of these vasculitis conditions. Now, when we turn our attention to the presentation here, lots of different things can present, but there's going to be some systemic symptoms. These can include things like fatigue, fevers, night sweats, or weight loss. But the ones I really want you to focus on are the cranial symptoms. New onset headache over the temple region. Typically, this is going to be unilateral. Remember, I said this can sometimes also be called giant cell temporal arteritis because of the unilateral headache at the temple, giving it its name. These patients can also have jaw claudication, which is pain with chewing. They also like you to know patients can present with vision loss, and a key word they want you to be familiar with is amaurosis fugax. Patients can also present with diplopia, which is double vision. Some additional symptoms can include things like abdominal pain, chest pain, limb claudication, and asymmetric pulses. But again, I want to think about what are these additional symptoms? How do they relate? What's the key problem here? The key problem is decreased vascular blood flow. So anytime we decrease vascular blood flow, what are things that can occur? Well, decreased blood flow to the gut can cause abdominal pain. Decreased blood flow to the chest can cause chest pain or angina-like symptoms. Additionally, limb claudication, right? Decreased blood flow, pain in the limbs, and asymmetric pulses as well. If one side is more affected than the other, we may not feel the pulses bilaterally with an equal amount of force. And again, we kind of already talked about it, but symptoms of polymyalgia rheumatica can be present. Now, when we turn our attention to the diagnostics here, some really key things I want you to know. Serum labs are going to have elevated ESR and CRP. Why is that? This is an inflammatory condition. There's more inflammation in the body. We expect our inflammatory markers to be increased. When we look at the histopathology here, and this is really the gold standard, this is really the best way to formally diagnose this condition in patients, is to look at a temporal artery biopsy showing panarteritis, mononuclear infiltration with formation of giant cells. There it is again, the giant cells, just like we see in the name, right? So I want you to draw your attention to this image over here, and you can see a handful of different findings. First of all, you can see all these mononuclear cells, right? All these deep, dark purple staining cells are mononuclear cells. You can also see the transmural panarteritis, right? You can see a lot of inflammation, particularly in the intimal portion of the image that is present. And a little bit harder to see here are these giant cells. But essentially, a giant cell is a fusion between a lot of smaller cells. So you'll see something that has multiple nuclei in it. So instead of just one cell with one nuclei, you'll see multiple nuclei. It's a fusion of macrophages. And we see these giant cells in a variety of different conditions. But giant cell arteritis is a key one that we need to know about in terms of vasculitides. Keep in mind, these can also be seen in other chronic inflammatory conditions such as sarcoidosis, Crohn's disease, rheumatoid arthritis, or in some infectious diseases such as leprosy or tuberculosis. Now, it's important to note that biopsy should be considered in all patients who have suspected GCA. But wait, there's one thing we have to consider, and we're going to talk about it right now with the management. So when we turn our attention to the management options here, we see that high-dose glucocorticoid therapy is the first thing on the list. Why is that? How does that relate to the diagnostics we just talked about? You want to initiate immediately the use of glucocorticoids if you suspect GCA is high to decrease the risk of complications. What are those complications? The classic one that they will test you on is blindness. We talked about this, right? Patients can present with vision loss, and we don't want that to happen. So it's very high yield that if you suspect GCA, although you may want to get the biopsy, which we talked about here, you need to start treating with the glucocorticoids first. And I put it right here on the slide. Untimely administration can lead to aortic aneurysms, brain ischemia, and or permanent loss of vision. The one I see them test the most common is the permanent vision loss. However, all of these things can occur, and these are very serious complications. So do not, if the question asks you which of the following is the next best step and you suspect giant cell arteritis, do not pick get a biopsy if you can give steroids first. You always give the steroids first before you do the biopsy because of this, because of the fear of a very serious complication occurring in the patient. So what might a typical vignette look like for these patients? They could give you something along the lines of a 68-year-old patient presents to the emergency department with new onset left-sided headache that awoke her from sleep earlier that morning. The patient reports she's in fairly good health, but often experiences joint stiffness in the mornings, for which she is currently seeing a rheumatologist. The patient reports feeling well the night prior, but she did notice a bit of jaw pain while chewing her food, which is unusual for her. On physical exam, the patient has mildly decreased vision of the left eye and tenderness to palpation over the left temple. The question could then ask which of the following is the next best step by the ED physician. They could then give you a variety of different option choices. They could make you think about headache treatment options with Tylenol, anti-inflammatories. They could talk about the biopsy if you're suspecting giant cell arteritis. They could give you the option of glucocorticoids or more imaging. There's a lot of different option choices they could give you. But again, we just highlighted this, and I can't emphasize it enough, high yield point. If you suspect giant cell arteritis, there are some very serious complications that can occur in these patients. You must give the high-dose glucocorticoids first before you consider doing some of these other things like a biopsy as well. So just a quick summary to wrap up this video. Giant cell temporal arteritis. This is one of our vasculitides, a vasculitis, inflammation of the blood vessels. This particularly is going to affect large vessels, but some medium vessels can be involved as well. Epidemiologically, typically going to present in an older female on a board-style question with a significant association to polymyalgia rheumatica. Pathophysiology here, again, we went into some details, but the key thing I want you to take is the body has a reaction that leads to vascular damage, excessive growth, and ultimately intimal hyperplasia, decreasing vascular blood flow. This is the idea here. We're causing ischemic episodes because of inflammation to the vessels. Presentation here. Systemic symptoms are going to be nonspecific, but the key things are going to be the cranial symptoms here. New onset headache over the temple, typically unilateral. This is really important. Unilateral headache with eye pain, new onset, Some jaw claudication or pain with chewing, and vision loss is a very classic presentation. When we talk about the diagnostics here, elevated inflammatory markers on serum labs would be expected. The gold standard to make this diagnosis is going to be the temporal artery biopsy. But again, we have to remember with the key point here, the management comes first. High-dose glucocorticoids is important to initiate if you suspect GCA because there's such a high risk of other complications occurring. Welcome back, everybody. David here again with Med School Boot Camp. So in this next video, we're going to talk about another vasculitis, and that is Takayasu arteritis. Remember, when we talk about our vasculitis diseases, we're talking about a rare group of autoimmune conditions that are characterized by blood vessel inflammation, which can ultimately lead to things like ischemia, necrosis, and damage to some of our organs. Now, oftentimes we break these up into large vessel, medium vessel, or small vessel vasculitides. When we talk about Takayasu arteritis, we are talking about a large vessel vasculitis. That is to say, we are typically affecting the larger vessels in the body. The other high-yield important large vessel vasculitis for you to know on test day is that of giant cell arteritis. So if we think about the epidemiology of Takayasu arteritis, we're typically dealing with a female patient that's between the ages of 15 to 45. As I often say, this does not mean this only occurs in females or it only occurs in this age range, but this is a very classic presentation that you want to be thinking about this condition. It's also important to note that this is most common in Asian individuals. Very often in board-style questions, they give you patient-related information or demographic factors because it's important to answer the question. It's important to think about who's most likely to have various conditions, even though anybody can present with them in real life. When we think about the pathophysiology here, it's really not well understood at this point, but the leading theories have to do with the fact that local inflammation leads to immune cell recruitment, which damages the vascular smooth muscles. This ultimately leads to transmural fibrosis and thickening of the arterial walls, which can lead to vessel occlusion, decreasing vascular blood flow, which in the end can lead to ischemia or organ damage. And so the way I kind of think about some of these pathologies here is if you have a vessel, right, with blood cells and it's kind of coming on towards you, imagine it's coming out of the screen, this vessel begins to undergo some inflammation, you get the transmural fibrosis, it just gets thicker and thicker and thicker and thicker, and ultimately, right, you kind of block off the vessel. You're not getting the blood flow through it, and that's what I think about with vessel occlusion and decreased vascular flow. So much inflammation occurs, so much thickening occurs that it actually decreases how much blood can get through the vessel. Now, when we think about the presentation here, I'm going to break this up into systemic symptoms and vascular symptoms. So our systemic symptoms can include things like fevers, fatigues, myalgias, and night sweats, which are not super specific in and of themselves, but indicates an inflammatory process or an inflammatory reaction, right? We can see these in vasculitis conditions. We can also see these types of presentations in cancers or even just general infections throughout the body. But where you can really differentiate this pathology from other pathologies is with the vascular symptoms. So this include things like a decreased brachial or radial pulses bilaterally, which just gives this disease the nickname pulseless disease. If you block off the blood flow, right, the blood does not get distally. You might not be able to feel those pulses because there's an obstruction earlier up in the system. This can also present with other things, including angina, carotid bruits, syncope, or ocular changes. And potentially, sometimes question writers will also include a skin finding called erythema nodosum, which is inflammation that can present on the skin as tender nodules and plaques. Again, this is not specific in and of itself for Takayasu arteritis because this can also be seen with malignancies, with pregnancies, with connective tissue diseases. But again, it's another clue that we can use on physical exam to draw a correlation with this pathology. If patients have several of these conditions, right, we need to have Takayasu arteritis on our differential. So when we're trying to work up patients for this, we need to consider some really important diagnostics. Again, this is an inflammatory condition, so our serum labs are going to have elevated inflammatory markers, including ESR and CRP. When we look at our imaging, we're going to consider a unique study called an MR angiogram or angiography or MRA. This is going to show stenosis or occlusion of the vascular lumen. And so if you draw your attention to our image over here, you can see multiple areas of stenosis throughout the vessels. You can kind of see the narrowing, right? You appreciate that this is pretty wide up here, and then there's this area right here, an indentation or a narrowing that's occurring. And these are the great vessels, right? These are the large vessels that are coming off of the aorta. This is why this is a large vessel vasculitis. And so this is a very important finding in making this diagnosis of Takayasu arteritis. Now, we can also consider histopathology, which is going to show the transmural fibrosis with granulomatous thickening of the aortic arch. We talked about the transmural nature up here in the pathophys, and now we see it again here in the histopathology. So if you draw your attention to this image right here, you can see a vessel, right? And I want you to appreciate this pink area around the vessel. This is the transmural fibrosis that is occurring. These are red cells in the lumen, and as this thickening process occurs and we get the decreased blood flow, this is what causes some of these classic physical exam findings. So we can see, we can relate the pathology to the histopathology to the clinical presentation in these patients. Now, when we think about the management here, the main ones they want you to know is that glucocorticoids and glucose-sparing agents are the key treatment options. So this is going to include things like cyclophosphamide or methotrexate. The idea being that you need some glucocorticoids, but you don't just want to give somebody tons and tons of glucocorticoids. There are reasons for that, right? There are adverse events and outcomes that can occur with prolonged or excessive use of steroids. And so you try to supplement that with another medication that does not have the same drawbacks or the same adverse events associated with it when you're treating these patients. Because in general, this is an autoimmune type condition or an inflammatory condition. We're using a lot of things to suppress that system, to suppress the inflammation or the reaction of the body to itself. We also want to consider things like surgery in an emergency situation. That is to say, if a vessel has completely occluded, which we talked about here, right? This is kind of end stage. You might need something like a vascular bypass for the severe stenosis, right? A vessel might start off with it gets a little bit of occlusion and then worsening occlusion, and then eventually it gets so occluded that it's basically cut off blood flow from getting through. Depending on where this vessel is, this might warrant emergent surgical intervention as blood flow is unable to pass through because of the stenosis being so severe. So how might this present in a question stem? Well, a possible question they could give you on test day includes something along the lines of a 41-year-old woman presents to her primary care physician with 3 weeks of malaise, night sweats, and intermittent chest pain. Vital signs are within normal limits. On physical exam, the physician notices soft radial pulses and auscultates a bruit on the left carotid artery. Laboratory results come back with an elevated ESR and CRP. The question could then ask you, which of the following would be the preferred imaging to work up this patient's condition? Now, we have to ask ourselves a few things here. What are the patient's symptoms? Well, they're fairly non-specific, right? There's some chest pain. There's a lot that can be going on there. There's some generalized malaise. There's a lot that can be going on there. But the key to this question is really the physical exam findings. A bruit in the left carotid artery, some weakened pulses distally. This is indicating the patient might have a vascular condition which is causing occlusion or leading to the pulseless disease that we talked about earlier in this video. And so the best imaging study would be the MRA or the MR angiography. This is the best way we're going to see the vessels and see where those areas of stenosis are. Other options they might give you could include things like an X-ray, right? That wouldn't be super helpful. CT, also less helpful, or an ultrasound can oftentimes trick people because they think an ultrasound is quick. It's financially cheaper to do oftentimes, but it's not going to give us the good image quality. It's not going to be the best image to really make this diagnosis of Takayasu arteritis. So just a quick wrap up for this video. Takayasu arteritis is going to be one of our large vessel vasculitis. Overall, we're typically going to see this in a 15 to 45-year-old, often Asian woman. However, that's not always the case. The pathophysiology is not well understood, but in general, it's an inflammatory process with immune cell recruitment that's going to lead to a thickening of the vascular system, which can ultimately lead to decreased vascular blood flow. Presentation are going to have non-specific symptoms such as fatigue, fevers, myalgias, or night sweats, but the specific findings or the vascular findings are going to really help us differentiate this pathology from some of the other ones. Classically, we're going to see decreased radial or brachial pulses. This is why this is sometimes called pulseless disease. Patient can also get symptoms of angina if they're not getting enough blood to the heart, carotid bruits if there's stenosis in the carotid arteries, syncope if we're not getting enough blood to the brain because we have stenosis in the arteries, and ocular changes as well for similar reasons. Diagnostics here, right? This is an inflammatory process, so our inflammatory markers are elevated. Best imaging is going to be the MRA, and we talked about why that is right here, and the histopathology is going to show this transmural inflammation that we talked about right here. Management is going to include things like glucocorticoids and glucose-sparing agents. Again, we want to calm down the inflammation. We want to calm down the autoimmune reactivity in the body for these patients. And if the patient has very severe case, surgical emergencies could be present. Welcome back, everybody. David here again with Med School Boot Camp. So in this next video, we're going to talk about a condition called thromboangiitis obliterans, which is sometimes also referred to as Berger's disease. So this is another one of our vasculitis diseases, which means it is an inflammatory condition that can affect vessels of different sizes. For this pathology, it tends to affect some of the small and medium vessels versus some of our large vessels, which are more likely to be seen in the Takayasu arteritis and giant cell arteritis, which we talked about in previous videos. So the overview with all these conditions is that we get vessel inflammation that can essentially cause a non-atherosclerotic obstruction. And as it gets bigger and bigger and the obstruction gets worse and worse, you can imagine that less blood flow is actually able to go through these vessels, which can cause a lot of key findings that we're going to talk about in this video. So if we turn our attention to the epidemiology here, we see that this condition is more common in men compared to women, and it typically is going to affect the 30 to 50-year-old age range. One of the really important things I want you to know for test day is that smoking is the most common cause of this condition. This is really important because later on we're going to tie this into the management options, and as I'm sure you can guess, not smoking is going to be a management option for this. If we remove the triggering factor for this condition, that's going to be one of our primary treatment options. So when we think about the pathophysiology here, we're dealing with increased local inflammation and immune cell recruitment that will damage the vascular wall, specifically, again, the small and medium vessels in this condition. We talked about previous videos, some large vessel conditions, and we'll talk about some future videos, some vasculitis diseases that typically are only going to affect the small vessels. But again, this is kind of a good way to arrange them in your brain. Does it typically affect the large vessels, the medium vessels, or the small vessels? You can see in this video, we're mostly dealing with these two right here. So once we have damage to the vascular cell wall, what's going to happen? Well, we're going to get increased local microthrombi formation, which is going to cause vessel occlusion and ultimately decrease vascular blood flow. Again, we kind of talked about this right here, but as the inflammation gets worse and worse, this can lead to other things like local microthrombi, right? You can imagine that as the inflammation gets worse and worse, a clot can develop, the clot kind of dislodges locally, and now we have kind of an obstruction right here where we're unable to get blood flow distally, right? Why? Because we have an obstruction. The clot has blocked off this area where blood flow would typically go. So again, it's important to keep in mind the pathophysiology here because a lot of the vasculitis conditions have a very similar pathophysiology in how they work, how their mechanism leads to the clinical presentation. Speaking of presentation, let's move on to the next portion where we'll see that patients typically have intermittent claudication, often in the hands, feet, or the calves. So why might this be? And what is claudication? Well, claudication is a type of pain or cramping sensation that typically affects an area that needs more blood flow but cannot get so. So this often presents itself during exercise, right? In the calves particularly, if we're exercising and we need more blood flow in the feet or the calves and we cannot get that blood flow there. Why can we not get it there? Well, because we have created an obstruction. The inflammation, the microthrombi has decreased our vascular blood flow. We get this finding of claudication. We want more blood to the area, right? Because it's exercising, it needs more oxygenation. It needs to have more of those red blood cells go to it. However, it's unable to do so. It's unable to meet the demand that it needs. This leads to a bunch of symptoms, pain, cramping, and this is all related to the fact that there's tissue ischemia occurring. It's not getting the appropriate amount of blood or oxygenation that it needs to meet the demand. Another key important finding they like to ask about is the migratory superficial thrombophlebitis. And these are basically tender nodules along a vein. This is important because you can sometimes feel these on physical exam, but this is also something you typically see prior to limb ischemia. That is to say, this is an earlier finding before the acute ischemia actually occurs. This is an important physical exam finding to keep in mind because migratory superficial thrombophlebitis is often seen in thromboangiitis obliterans and also Behçet's disease, but it's not typically seen in other vasculitis conditions. Another key important presentation includes Raynaud's phenomenon, which is vasospasms that tend to occur in the distal extremities, such as the fingers or toes. This can lead to kind of a whitening of the digits when they are undergoing stress or are cold. Patients will also present with progressive symptoms similar to peripheral artery disease. These can be things like cool extremities, skin ulcers, gangrene, or pain at rest with mild exertion. Again, this is kind of our claudication presentation. So this all has to do with the fact that in peripheral artery disease, as well as in this condition here, we are getting vessel occlusion and decreased vascular blood flow. So if we're not getting enough blood flow distally, we have a variety of symptoms that patients will present with. Now, when we think about the diagnostics here, another really important point to differentiate this vasculitis from some other vasculitides includes the fact that we'll typically see serum labs with a normal ESR and CRP. Remember, in a lot of the other videos, we talked about how these would be elevated because it's an inflammatory reaction. However, for reasons that are not completely understood at this time, ESR and CRP tend to be normal in this condition. So that's a very vital key differentiating factor from some other vasculitis conditions that might have a similar presentation. Also important to note that imaging can show non-atherosclerotic segmental lesions and vessel occlusion. Sometimes this can be seen with a Doppler ultrasound, but arteriography is going to be the preferred image. And if you draw your attention over here, we can see how good this image really is. And you can really appreciate right here where the arrows are showing that we have blood flow going down, right? We have the white area right here. And then there's a bit of a decrease in how much is reaching distally. That's because there's an obstruction right here. There's some vessel occlusion or stenosis that is occurring, which is not allowing the blood to continuously flow down to the distal extremity. We can also see another one right here as well, along with over here. Now, they also like you to know about the ankle brachial index, and that it is typically decreased, but it can be normal. So just as a reminder, if you're unfamiliar with the ankle brachial index, this is a ratio of the systolic blood pressure of the ankle relative to the systolic blood pressure of the brachial artery. So you get your normal blood pressure read on the arm, and then you would also take an additional blood pressure read distally near the ankle, and you compare that ratio. Normal ABI is going to range between 0.9 and 1.3. That is to say they're fairly similar, but as patients get progressive peripheral artery disease or progressive obstruction distally, that ratio is going to decrease. The systolic blood pressure in the ankle is going to become a lot less than the systolic blood pressure in the brachial artery. And so values less than 0.9 indicate PAD, which can get increasingly severe over time. So in summary, this condition can present with a decreased ankle brachial index if there is some obstruction, but not always. It can be fairly normal. It can have a fairly normal range if it's early disease or there's not significant decrease in vascular blood flow. Now, when we think about the management here, just to wrap back to the beginning of the video, we talked about the most common cause of this condition is smoking. So what's a really important management strategy? Well, it's going to be smoking cessation. This is a very high yield component, right? If they gave you a test question and they said, what's the best next step for somebody who has a 20-pack year smoking history and is presenting with a lot of these classic findings, the first thing to do is to counsel them on smoking cessation, encourage them to stop doing the thing that is causing the pathology in the first place. We can also consider some other options, such as medical therapy for symptom management. These can include calcium channel blockers, iloprost, and hyperbaric oxygen. If patients have very severe disease, we can consider surgical intervention, which may be needed for debridement or amputation. Remember, one of the things that can occur if this gets severe is going to be gangrene or even skin ulcers. This might actually require surgical debridement if it gets far enough. If you look over here to our image, you can see this foot is not quite the same as the right foot. This is chronic distal ischemia. This is presenting with a gangrenous appearance. This might potentially need surgical intervention to help treat this patient. So, question writers can ask a lot about this condition, but a potential question stem they could ask you includes something along the lines of a 40-year-old male with a 20-year smoking history presents to the primary care provider with approximately 1 month of intermittent pain and color changes in the toes. He reports symptoms have been progressively worsening. Vital signs are within normal limits, except for mildly elevated blood pressure, which is controlled with medications. Labs are drawn, and it's noted that cholesterol panel, ESR, and CRP are all within normal ranges. The question could then ask which of the following is the biggest risk factor for this patient's condition. Now, you're probably jumping to smoking right away, but I want to unpack this a little bit, right? We said the patient has a 20-year smoking history, so it makes sense they should stop that. But what's a key thing in the question stem? It's that the cholesterol panel is normal. Recall, this is an inflammatory condition, but it is a non-atherosclerotic condition, right? Peripheral artery disease is typically dealing with atherosclerosis that creates an obstruction so blood cannot move distally. Here, we're dealing with more of an inflammatory process and microthrombi that create the obstruction in which blood can also not move distally. So it's a similar presentation. However, the pathophysiology, the mechanism behind it, is different than our peripheral artery disease, and that's why the question stem was telling you that the cholesterol labs were normal. So keep this in mind on test day. So just a quick summary to wrap up this video. We're talking about thromboangiitis obliterans, sometimes also called Berger disease. Typically, this is going to present in a 30 to 50-year-old male who has a history of smoking. The pathophysiology is similar to a lot of our other vasculitis conditions in which we get local inflammation that can lead to vessel occlusion and ultimately decrease vascular blood flow. When we talk about the presentation here, we think about things that would occur if a patient had less distal blood flow to the extremities. A very classic one is going to be the intermittent claudication. We talked about migratory superficial thrombophlebitis, and this can be an early sign of what is to come in terms of ischemia to distal tissues. Patients can also present with Raynaud's phenomenon, as well as similar findings that you would see in PAD. When we think about the diagnostics here, key differentiating step is that typically ESR and CRP are within normal limits. Compared to a lot of our other vasculitis conditions, we would expect these ESR and CRP markers to be elevated given the inflammation in the body. One of the best ways to look at this is going to be doing an arteriography to really see these non-atherosclerotic segmental lesions. Keep in mind you can use a Doppler ultrasound, but it's not as good. It's something you could use quickly at bedside, but you're really going to want to get this imaging to really confirm the diagnosis. We also consider the ABI ratio is typically decreased, but it can be normal. And when we think about management here, the most common cause is smoking. That's what causes this condition. So one of the best things we can do to prevent this condition or try to treat it is to have patients stop smoking. We can also consider some other things such as medical therapy or surgical intervention if a patient were to have a particularly bad case. Welcome back, everybody. David here again with Med School Boot Camp. So in this next video, we're going to talk about Kawasaki disease. This is also sometimes called mucocutaneous lymph node syndrome. So Kawasaki disease is a type of acute vasculitis that is typically going to affect medium-sized vessels. However, there is some overlap between the vessels that it can affect. Remember, a vasculitis means that we have inflammation of the blood vessels. And so Kawasaki is an example of that. Particularly, Kawasaki disease tends to affect the coronary vessels, and we'll talk more about why that's important coming up. So if we start with the epidemiology here, this is slightly more common in males compared to females, and is typically going to affect a younger child, often less than 5. There's an increased prevalence in Asian and Pacific Islander descent, and this is often given to us as a clue in board-style question stems. When we think about the pathophysiology here, unlike with some of our other vasculitis conditions, overall, this one is not really well understood. It's thought to be multifactorial. It's suspected that an infection can increase the immune response in genetically predisposed individuals. So that is to say, somebody who is genetically predisposed, who gets an infection, might have an overreaction that leads to this condition. Somebody who is not genetically predisposed could have the same infection, but they never develop Kawasaki disease. So this is still an area of research that's ongoing. But if you just keep in mind that this is a vasculitis or an inflammatory blood vessel condition, that should be good enough for test day. When we think about the presentation here, there's some very classic findings that we're going to see. And one of the most useful memory aids that I remember for taking these exams is going to be crash and burn. So let's unpack that a little bit. The C in crash is for conjunctivitis. This is typically a painless, bilateral conjunctivitis without exudates. This is important because it's kind of in contrast to maybe a bacterial conjunctivitis, which is more likely to have exudates coming from the eye. The R stands for rash, and this is often a desquamating or polymorphous rash, which means it can have many different forms, but it often presents as small, tiny bumps that can be raised from the skin. When we think about the A, this stands for adenopathy. This is typically going to be unilateral cervical lymphadenopathy. So if you're feeling a patient's neck and you're feeling for the lymph nodes, typically one side is going to be inflamed and the other side would not be. The S in crash stands for strawberry tongue. This is sometimes also called oropharyngeal mucositis, and it'll present as redness and cracked lips. Now, just to draw on some other conditions, can we think of another very commonly tested pathology where patients can present with a very classic strawberry tongue? That's right. Patients who have scarlet fever. Remember, scarlet fever is something that can happen to people who get the group A strep. And so that's why we have to use all of the clinical clues, right? Just the strawberry tongue finding does not tell us if we're dealing with scarlet fever versus Kawasaki disease. So we have to use the entire clinical picture. But here's kind of an overlap of a physical exam finding that you can see in multiple different pathologies. Keep in mind the strawberry tongue finding can also be seen in some allergies to foods or drugs as well. Now, the H in crash stands for hand/feet, erythema, and edema. So these patients are often going to present with redness in their hands and feet, and they can be swollen as well. So there is our first portion of the memory aid, which is crash. C-R-A-S-H, conjunctivitis, rash, adenopathy, strawberry tongue, and hand/feet erythema and swelling. And then the easy one is actually to remember the burn component of the memory aid. This is dealing with patients who have a fever, often for more than 5 days. This is a pretty unique finding. This is important to keep in mind when you're reading the question stem. Oftentimes when patients have a viral condition, the fever may only last for 2 or 3 days. But if they're talking about a patient who has a fever for 4, 5, 6, even a week long, that's a bit longer than we would typically expect in a normal viral condition that is going to self-resolve. When they talk about 5 days of fever, I want you to really think about Kawasaki disease, particularly if they pair that in the question stem with a young child. And so altogether, that's our memory that's super helpful. When you think of Kawasaki disease, I want you to think of crash and burn. You may know that Kawasaki is also a brand of motorbikes. And so if you imagine a young kid riding a motorcycle or a motorbike, potentially a Kawasaki dirt bike, and you can make this association in your brain, you remember all of the clinical presentations that they're likely to ask you about on test day. The crash talks about the physical manifestation, and the burn refers to the prolonged fever, typically about 5 or more days. Now, when we think about the diagnostics here, remember this is an inflammatory condition, so we typically see elevated inflammatory markers, including ESR, CRP. In addition, we can also see elevated liver enzymes such as AST and ALT, as well as increased white cells and platelets. But the really important thing I want you to remember here from the diagnostics is the imaging. These patients need an echocardiogram to assess for coronary artery aneurysms. This is one of the feared things that we think about with this condition. A young child who has Kawasaki disease having a coronary artery aneurysm is a big deal. This is a life-threatening thing potentially. And so we have to make sure that we monitor it in these patients. So if you draw your attention to the image over here, you can see nicely this kind of dilation that's occurring, right? The arrow's pointing to, which is an aneurysm. And this is why it's so important to get this imaging in these patients. You need to identify these early on so that we can hopefully do something about it, or at the very least, monitor it for any changes. Something to consider is that these patients often need serial echocardiograms. So you'd get one done at the time of diagnosis, and you may see something like this. But even if it looks normal, you would want to get additional follow-up imaging at 2 weeks after onset and additionally 6 to 8 weeks after onset as well, in case there's a bit of a delay before the aneurysm actually develops. These patients are also at an increased risk of myocardial infarction, myocarditis. So you can see Kawasaki disease has a very big component with affecting the heart. We're very concerned about that, particularly in such a young patient. When we think about the management here, really highly tested stuff they like to ask about this. Patients will need to get intravenous immunoglobulins. You will often start with a high dose, and this is to decrease the risk of coronary artery aneurysms, MIs, or some other things that we talked about. But the really unique one that they love to test about is the use of aspirin. I put a high yield point here, and why might that be? Well, if you recall, we typically avoid aspirin in young patients. And the reason for this is because children are at an increased risk of developing something called Reye's syndrome. And this is a rare type of hepatic encephalopathy that can occur in children less than 18 years old who take aspirin. And so in general, it's ill-advised to give children this medication. And Kawasaki is the exception to the rule. If a patient has a typical viral illness, you want to avoid aspirin because the risk of developing this other condition is too high. But in Kawasaki disease, a pro versus con analysis, giving the aspirin is important for protecting the heart. It's protecting against the possible myocardial infarction or some other very bad things that could happen to a child. And so you have to consider this, and these patients actually will be treated with the aspirin in addition to the IVIG. Very commonly tested question because it's so different than what we typically do. So a potential question they could ask you on test day could be something along the lines of a 5-year-old patient presents to the pediatric emergency department with a new onset stomach rash. The parents report the patient has not been feeling well for almost a week, and they are concerned that the patient's younger sibling will begin to feel ill soon. They do not have a thermometer at home, but report the patient has felt warm the entire week. On physical exam, you notice conjunctival injection and small red bumps all over the patient's torso. Temperature is found to be 38.2 degrees Celsius on arrival. The question could then ask, which of the following should the child be treated with at this time? They could give you several answer choices, including antibiotics, antifungals, Tylenol, immunoglobulins, ibuprofen, aspirin, but the best answer was going to be the one that includes IVIG and aspirin, or if they just offer one of them, it would be aspirin or IVIG. Antibiotics are not going to be the best here. Antifungals are not going to be the best. Tylenol is not going to be the best, even though we often use that as a fever reducer. This patient has a lot of classic signs and symptoms of Kawasaki disease, and we need to treat that appropriately. So just a quick summary to wrap up this video, we're talking about Kawasaki disease, sometimes also called mucocutaneous lymph node syndrome. Epidemiology-wise, this is typically going to present in a younger child in a board-style question. The pathophysiology is not well understood, but it's a combination of inflammation and overreactive immune system. But the key here is the presentation, right? You want to remember this memory aid, crash and burn. CRASH, conjunctivitis, rash, adenopathy, strawberry tongue, and hand/feet erythema amoeba. Burn standing for the fever, which is often greater than 5 days. Elevated serum markers are going to show increased CRP, ESR, along with LFTs and WBCs/platelets. The key here with the diagnostics, though, is going to be the imaging, the echocardiogram. Why do we need that? We need to assess for coronary artery aneurysms. This is a very feared complication of young children with Kawasaki disease, so we need to monitor this over time. The management here is going to deal with IVIG. Again, this is to decrease the risk of coronary complications. And the unique treatment here is going to be the aspirin with a high yield button next to it, because we don't typically use aspirin for young children. We don't typically use it for patients under 18, but this is an exception to that rule. Welcome back, everybody. David here again with Med School Boot Camp. So in this next video, we are going to talk about an important condition called polyarteritis nodosa. Sometimes this is just abbreviated as K.A.N. So polyarteritis nodosa is a systemic condition. Specifically, it's a systemic vasculitis. I mean, there's inflammation of the blood vessels. This tends to affect the medium-sized vessels primarily. However, there is some overlap between these conditions. Remember, this is kind of important to keep in mind when we think about which ones are primarily going to affect our large vessels, such as Takayasu arteritis and giant cell arteritis, and there are a bunch of vasculitides that are going to affect the small vessels primarily, and we'll talk about those in upcoming videos. One of the key things I want you to remember throughout this video is that polyarteritis nodosa affects many different organs. This can be the GI system, the kidneys, the heart, the nerves, and even the muscles. And the way I remember this is that the root word poly means many, and in this case, we're dealing with many organs, or many organs are involved. So when we turn our attention to the epidemiology here, the first thing to note is that primary polyarteritis nodosa can be idiopathic. That is, we don't necessarily know what causes the condition to present. However, there are a variety of secondary causes. That is to say that polyarteritis is secondary to another primary cause or another primary pathology. These can include autoimmune conditions such as sarcoidosis, SLE or lupus, and Sjogren's syndrome. It can also be due to infections. Some of the common ones they test are HBV, HCV, HIV, syphilis, or tuberculosis. And typically when we think about the average age range, we're looking at around a 45 to 65-year-old patient. But as I always say, this is not always the case. It's just kind of the most classic presentation. Now, when we turn our attention to the pathophysiology here, we can see that this is due to systemic vascular inflammation, typically of medium-sized vessels, which we talked about, which ultimately leads to tissue ischemia. Again, if we get significant vascular inflammation, right, we have a vessel, it gets really, really inflamed, this can cause a little bit of an obstruction. This can lead to tissue ischemia, as not as much blood flow can actually go through the vessel itself. And it's important to keep this pathophysiology in mind because this explains a lot of the classic findings that we see in these patients. So if we draw our attention to the presentation here, patients can have some systemic, non-specific findings such as fevers, headaches, malaise, myalgias, or weight loss, but they can also have organ-specific involvement, and this is what I really want to focus on in this video. So think about a lot of our primary organs and think that this condition typically will affect those. We'll talk about one which it does not affect, which is fairly unique at the end. But the first thing I want to think about is the cardiovascular system. So this condition is going to increase the risk of myocardial infarction. And if we think about our pathophysiology, this should make sense to us, right? Because what's the pathophysiology behind myocardial infarction? It's tissue ischemia, tissue death, right? Patients who have polyarteritis nodosa have vascular inflammation that leads to tissue ischemia, which is obviously going to increase the risk of a myocardial infarction. You can see here that the presentation or the clinical findings are directly related to the pathophysiology in these patients. Now, if we look at the next one, we can see a similar thing. Renal problems can occur. You can get renal dysfunction and even hypertension. Again, draw it back to the pathophysiology here. Tissue ischemia can lead to destruction of organs, including the kidneys, so that they don't function quite as well. This can also lead to hypertension as the kidneys are not as well able to regulate our blood pressure. Kidneys play a vital role in our sodium and water balance. If the tissues are dysfunctional, we're not able to regulate this very well, which can lead to a classic presentation of hypertension. Now, if we think about cutaneous findings, these patients can have skin nodules, rashes, or even ulcers. Again, part of this can be due to pathophysiology with tissue ischemia, but when I think about rashes, nodules, and ulcers, you have to also consider that a lot of these patients have an underlying autoimmune disease, right? We know sarcoidosis, lupus are very classic conditions that can present with a rash, so it kind of makes sense that these presentations can go together depending on the patient's clinical history. We should also consider the GI system or the gastrointestinal system. Patients can have abdominal pain, nausea, and vomiting. Again, gets back to the pathophysiology. Neurologically, patients can have a polyneuropathy or mononeuritis multiplex, which is a pretty unique finding. This is an asymmetrical deficit to typically more than 2 peripheral nerves that are located in separate areas. So that is to say we can have multiple seemingly unrelated nerve polyneuropathies. A classic example could be somebody who has sciatic nerve pain in the lower extremity on the left side, along with a right upper extremity radial nerve pain or radial neuropathy. This would be an example of asymmetric peripheral nerve involvement in the patient's condition. Now, key point they'd like you to know here is that we talked about all of these organs that are involved, but typically the lungs are going to be spared. And this is particularly important, and they really like to test this concept. And a pretty commonly used memory aid for this condition is to remember P.A.N., to remember the pulmonary artery is not involved. So again, P.A.N., pulmonary artery not, or pulmonary artery is not involved. This is how we remember that in this condition, the lungs are typically spared. Now, when we think about our diagnostics here, this is going to be an ANCA negative pathology. This becomes important as we talk about some of the small vessel vasculitides and other pathologies in this chapter. Some are ANCA positive, some are ANCA negative. So this can kind of be a helpful test for determining which pathology is most likely. We also need to consider that imaging is important and that visceral angiography will show multiple microaneurysms in a string of pearls appearance. So if you draw your attention to this image up here, you can appreciate a lot of these aneurysms that they're showing in the image. So again, as the vessels become inflamed, become damaged, they can have some bulging effect or aneurysms that actually present. And we can see these. Now, they also like you to know a little bit of the histopathology in that you see transmural inflammation with leukocytic infiltration and fibrinoid necrosis. So again, now draw our attention to this image over here, and I want you to appreciate this transmural inflammation that we're seeing around the vessel itself, along with kind of this inner layer, which is the fibrinoid necrosis. Recall that transmural inflammation means it involves all layers of the structure, and fibrinoid necrosis is a type of necrosis in which there's a deposit of fibrin and other proteins that result in kind of a bright pink appearance on H&E staining. Now, finally, we need to know a little bit about the management here. Main thing for these conditions is that they are inflammatory conditions. So how are we going to manage those? With glucocorticoids and potentially another medication called cyclophosphamide. Cyclophosphamide is a type of alkylating agent, which can be used in a variety of different autoimmune conditions or even some cancers. Also important to know, this really key association is that these patients potentially need antiviral therapy if it's HBV-associated PAN. This is a commonly tested association on test day. We talked about it here. We talked about it here again. Hepatitis B being associated with PAN has historically been a classic test question. But again, this does not mean every question is going to talk about a patient with hepatitis B, but in general, the question writers are giving you information or clues that are trying to help you answer the question, right? The goal is not to trick you, it's to try to facilitate your understanding of the question so you can get questions correctly. So it's important to keep in mind all these things when you're doing questions, although the association is not there all the time, but it's just something to be mindful of on test day. So a possible question stem they could ask you for this question includes something along the lines of, a 48-year-old patient presents to the emergency department with abdominal pain, fever, and myalgias. The patient denies any known medical history and states they work as a sharps collector at the local hospital. Vital signs are notable for a blood pressure of 157/99 millimeters of mercury. On physical exam, the patient has abdominal tenderness and several small skin ulcers in the lower extremities. The patient is also noted to have decreased sensation in the left hand and foot. The question could then ask, which of the following is the best study to confirm the patient's diagnosis? Now, they can give you a whole bunch of option choices here. They can give you some serum labs, talk about inflammatory markers. They could even talk about the ANCA positivity or negativity in this case. They could give you these two options, which is really going to draw students' attentions. The angiography showing the microaneurysms or the biopsy, right? The histopathology. The best answer in this question would actually be to do the biopsy and the histopathology to truly confirm the diagnosis. The reason being that this string of pearls appearance in the angiography, although it would be very useful in terms of other clinical clues to make the diagnosis, is not necessarily specific for this condition. That is to say, string of pearls can also be seen in other conditions such as fibromuscular dysplasia. So in this particular question, if they give you both options, the best answer would be the histopathology here. However, it's very reasonable that you could make the diagnosis based on a lot of these clinical findings and this imaging by itself. So just a quick summary to wrap up this video. We're talking about polyarteritis nodosa. Remember, poly meaning that it affects many different organs. Primarily, this is going to be idiopathic, but there are a variety of different secondary causes, including autoimmune conditions and infections, particularly the hepatitis B they like you to be familiar with, a very common association that is tested. Pathophysiology, this is really just due to systemic vascular inflammation leading to tissue ischemia that can present with a variety of different findings that affect lots of organs, including the heart, kidneys, skin, GI system, and neurological system. Typically, this is going to spare the lungs as well. Remember the classic memory aid, P.A.N., pulm artery not affected, or pulmonary artery is spared. When we think about the diagnostics, this is typically going to be ANCA negative. We have an imaging option right here with angiography, as well as a biopsy option for histopathology. Management here is really going to revolve around glucocorticoids and cyclophosphamide, and antiviral therapy for patients who have the HBV-associated polyarteritis nodosa. Welcome back, everybody. David here again with Med School Boot Camp. So in this next video, we're going to talk about Behçet's disease. And remember, we're still talking about our vasculitis conditions. We're still in our vasculitides chapter. And so this is a similar pathophysiology. This is a type of inflammatory vascular condition that can present with a variety of different findings. As I always say, I really want us to focus in what are the key differentiating features between all of these conditions, right? There's tons of pathology we're going over in this chapter, but the really best way to get answers right on test day are to know a couple of things that differentiate this from some of the other conditions. So if we think about the epidemiology here, this is typically going to be more common in males than females and in a younger patient population, right? Our 20 to 40 years old. We can pair this with something like our giant cell arteritis, where we're talking about an older patients, typically 60, 70, or 80 years old. So we always want to keep this in mind because it's the first thing the question writers are going to give us on test day, right? A so-and-so year-old patient presents to whatever setting, right? So we want to keep the age and the approximate age where these conditions show up to give ourselves a little bit of a framework of what pathologies might be at play. Again, these are not exclusive. It doesn't mean these can only occur in these age ranges, but it just gives us a general idea. Now, it's also important to note there's an increased prevalence in Eastern Asia and Mediterranean regions. So if they give this information in a question stem, they might be giving it for a reason to help lead you toward the diagnosis of Behçet's disease. Another key point is that there's an association with HLA-B51, family history, and infections, particularly HSV or parvovirus. So these are other clues they can give you in a question, talking about a patient who recently had parvovirus. Now they're presenting with some of these other symptoms. So when we think about the pathophysiology here, we don't have to get too in-depth, but it's important to know this is due to increased autoimmune activation, leading to increased immune complex formation and deposition in the tissues. What happens then is the body reacts by sending more CD4 T cells that release cytokines and increase the neutrophil activity, and ultimately there's tissue damage that can lead to a variety of different findings. So again, the general principle here with all these conditions, we talk about body has an overactive response to a stimulus, which ultimately leads to damage to surrounding tissues and often decreased blood flow as well. Important to know here in this condition, it doesn't have a real predilection for large vessels versus medium versus small vessels. Sometimes in the videos we can talk about those things. With GCA, it's typically large vessels. With microscopic polyangiitis later in this chapter, it's typically small vessels. But here, they can kind of affect all of the vessels, large, medium, and small. Now, when we think about the presentation here, I listed the important ones I want you to know for test day. These include cutaneous ulcers, such as aphthous ulcers or genital ulcers. And it's important to note that these are typically going to be painful. And if you draw your attention to this image over here, you can see one of those ulcers in the patient's mouth. Now, oftentimes, this is the initial presenting symptom. A patient will develop this. This might be the first thing that they see. These usually resolve within a few weeks. However, it's important to note that these are often recurrent, so it's painful and recurrent as well. Now, similar thing with genital ulcers. These are most common to present in the vulva or the scrotum, but they can present anywhere around the genitalia. So again, we have ulcers either in the mouth or in the genital region. Now, we also commonly see erythema nodosum, and we've talked about this one previously, but just as a quick reminder, if you draw your attention to this image right here, erythema nodosum is an inflammatory condition which presents with these kind of tender nodules on the skin. Now, there are some other findings as well that are a little bit more nonspecific. These include things like arthritis, GI symptoms, and vascular pathologies such as superficial thrombophlebitis, which remember is inflammation of a superficial vein. You can actually feel it on a physical exam, or other things which are deeper, such as a DVT or Budd-Chiari syndrome can be present as well. Now, there's a pretty unique finding that can present in a subset of patients, approximately 5 to 10%, called neuro-Behçet syndrome. So these are the above findings, plus cognitive changes, paresis, and hearing loss. So you really see some integration with the central nervous system here. And if we have the central nervous system symptoms as well, we call it neuro-Behçet syndrome. Now, when we think about the diagnostics here, important to know this is mainly a clinical diagnosis. We don't necessarily need a ton of labs or tests. It's really based on symptom presentation, particularly if we have the recurrence of these painful ulcers in a variety of different conditions, maybe some of these risk factors or history as well. We can, however, check the serum labs, which is likely to show an elevated ESR CRP, again, because this is an inflammatory condition. and it's going to have a negative ANA, ANCA, and rheumatoid factor. So that is to say, a lot of these tests that we use to look for autoimmune conditions are typically going to be negative in this condition. And the importance of these negative autoantibodies in Behçet syndrome is that it helps differentiating with other autoimmune conditions where we might see positive ANA or positive rheumatoid factor or positive ANCA. Now, one unique test they might mention in a question stem or ask you about is the positive pathogy skin test. So what that entails is a sterile needle is actually pricked into the skin and then checked a couple days later. If the test is positive, a red bump will form under the skin where the needle was inserted. This indicates an overreaction by the body or an overreacting immune system, which can be used as a helpful clue in diagnosing Behçet syndrome. Now, how are we going to manage these patients? Well, oftentimes this is going to be symptom-specific management. So if they have ulcers, they may need topical steroids. If they have the signs of arthritis, we talked about up here as a non-specific symptom, they may need colchicine, and patients may also need immunosuppression. High-dose glucocorticoids and immunosuppressants may be needed for severe disease. So if patients have a lot of these findings and they're causing really bad symptoms, they might need some pretty high-dose medications. So what's a question stem they might ask about for this pathology? They could say something along the lines of a 41-year-old woman who recently moved from Greece presents to the primary care provider to establish care. The patient feels well overall, but reports an oral ulcer for about the past week. On physical exam, we note conjunctival injection, in addition to painful pretibial subcutaneous nodules. Vital signs are within normal ranges. Laboratory results come back with an elevated ESR, CRP, and a negative ANA. The question could then ask which of the following genes is associated with this patient's most likely condition. Well, if we think about our question here, right, they gave us the origin of the patient, right? They talked about she's moved from Greece. We gave the approximate age range was a 41-year-old patient. She has these oral ulcers. She has these pretibial tender nodules, potentially consistent with erythema nodosum, and it's asking for what's the most likely gene. So they gave a lot of clues here that are indicating this patient has Behçet's disease or Behçet syndrome, and they're asking what's the associated gene, and they like to do this. And so it's important to know that this is associated with the HLA-B51. That is to say, this patient has a predilection or a predisposition based on genes to acquire this condition. Now, just a quick summary of this video, we're talking about Behçet's disease. Epidemiology is typically going to be in a young to middle-aged patient, and there are key associations with both genes, family history, and infection history as well. Pathophysiology here, it's all about the fact that the body overreacts to a stimulus that can ultimately destroy the tissues and lead to vascular inflammation. Presentation here, we're often going to see cutaneous ulcers. These can be aphthous ulcers, genital ulcers, maybe even some erythema nodosum or uveitis as well. You can see this kind of conjunctival injection, this inflammation around the eye is a very classic finding. Additionally, there can be some non-specific symptoms such as arthritis or GI symptoms as well. Neuro-Behçet syndrome is a subclass of patients who develop CNS-type changes. When we talk about the diagnostics here, mainly a clinical diagnosis, serum labs can show elevated inflammatory markers, but typically are going to show negative autoimmune antibodies. When we think about the management here, it's typically going to be symptom management. So this is going to depend on what symptoms the patient's presenting with. If they're presenting with all the symptoms or they have a severe case of the disease, we might have to consider high-dose glucocorticoids and immunosuppressants as well. Welcome back, everybody. David here again with Med School Bootcamp. So in this next video, we're going to talk about a fairly low yield pathology in this section. However, I want to be complete and make sure that you are prepared for everything on test day. So in this one, we're going to talk about cutaneous small vessel vasculitis. Sometimes this is abbreviated as CSVV. Historically, this has also been referred to as hypersensitivity vasculitis. This is a type of vasculitis that typically affects small vessels, as the name suggests. Again, we try to categorize these in our brain as things that affect larger vessels versus medium vessels versus smaller vessels. And it's also important to note that this vasculitis typically affects the skin. However, other organs are fairly uninvolved. So when we think about the epidemiology here, this is typically an idiopathic condition and that we don't know the primary reason for it occurring. However, it is associated with a variety of autoimmune conditions such as lupus, infections such as HIV or HCV, along with medications such as allopurinol, cephalosporins, penicillins, and sulfa medications as well. Particularly when we talk about these drug reactions, it's important to keep in mind that there's usually a delayed response, right? So a drug-induced reaction can occur approximately 7 to 10 days after someone had a triggering medication. So a patient says they started a new medication last week. It's one of the ones that can potentially trigger this, and now they're presenting with a variety of clinical findings of their skin. We want to be thinking about this condition. Now, when we think about the pathophysiology here, this is thought to be due to increased immune complex formation and deposition in the tissues, which ultimately increases the complement system activation, leading to neutrophil activity and recruitment, which can cause vascular inflammation and damage to a surrounding area. So that is to say there's an overabundance of immune cell activity in a particular area that can actually damage the tissues and lead to some of our clinical findings. When we think about the presentation here, the classic and main one they want you to know is the painful, palpable purpura. And so if you draw your attention to this image right here, we can see the purpura, which is this kind of purplish reddish lesion on the skin that is non-blanchable. What does that mean? When I push on the lesion, the color does not dissipate, right? Versus more of a vascular condition where you push on the skin, the blood goes away, it gets more of a white appearance. Here, if you push on the area, it will still continue to have this reddish purplish appearance. It's called palpable purpura because it's a little bit elevated. You can actually feel it. If you run your finger along the skin, you'll feel the regular cutaneous tissue, and then you'll feel kind of the elevations as well. This is the palpable purpura, which is typically painful in this condition. And again, it's important to keep in mind that in this pathology, there's no significant visceral involvement. There's no significant involvement of other organs. This is primarily a skin finding that can present in a variety of different ways, including the purpura we talked about, but it can also present with ulcers, urticaria, and vesicles as well. Now, when we think about the diagnostics here, the main one I want you to focus on for test day, the main differentiating feature is going to be the cutaneous biopsy showing leukocytoclastic vasculitis. So if you draw your attention to this image over here, you can see an assortment of neutrophils in the area with the dark purple staining, in addition to some fragmented nuclei. And so this collection of findings is known as perivascular inflammation, which is a neutrophil predominant. And that's why this is referred to as a leukocytoclastic vasculitis. Now, when we think about the management here, the first thing to do would be to treat the underlying condition. If it's a medication that's provoking the reaction, then we need to discontinue that medication. We also want to include things like symptom management, which can include rest, maybe anti-inflammatories, ice, compression, elevation, depending on the findings the patient is experiencing at that time. And if the disease is very severe, we'd have to possibly consider using glucocorticoids or glucocorticoid-sparing agents, such as methotrexate or rituximab. So in a question stem, they might ask you something along the lines of, a 54-year-old patient presents to the emergency department with new onset painful redness in the lower extremities. The patient reports they are in fairly good health, and I've never had this rash before. The patient does report having some recent lower extremity swelling and states they were prescribed a water pill by their primary care provider approximately 1 week ago. Vital signs are within normal ranges. On physical exam, the physician notes non-blanching purple areas that are tender to palpation. The question could then ask which of the following should first be considered in the treatment of this patient's condition. Now, this is a bit of a tricky question. What does the patient have going on? Well, they have a rash, right? It's a non-blanching, painful, palpable rash. What could be the cause of this rash? Well, one of the key clues in this question is that the patient was started on a water pill approximately a week ago. A classic water pill patients are started on for lower extremity swelling is Lasix or furosemide. And furosemide is a drug that fits into the sulfa group of medications. And so this presentation, a delayed onset approximately a week later after starting a new medication, sulfa, indicates this patient might be having a reaction or cutaneous small vessel vasculitis that is presenting with painful palpable purpura. So one of the first things we should do to treat this patient is to stop the offending agents, right? We said to discontinue provoking medications if suspected. My suspicion in this patient is high that this medication, a sulfa medication, is causing the symptoms. So this would be one of the first things that I would do to help treat this patient's condition. And that would be one of the correct answers for this question. So just a quick summary to wrap up this video. Again, overall fairly low yield compared to some of the other videos in the chapter, but this is cutaneous small vessel vasculitis or CSVV. Primarily, this is going to be idiopathic, but there are a variety of different secondary causes such as autoimmune conditions, medications, or infections that can be related to this as well. Pathophysiology is going to be due to immune complex formation, deposition, activating the complement system that leads to vascular inflammation. The presentation here is really going to focus around the skin findings, right? The painful palpable purpura, the ulcers, the urticaria, vesicles. Typically, there's not going to be significant other organ involvement. Diagnostics here really going to focus around the biopsy, the leukocytoclastic vasculitis, which we talked about here. And management is going to deal with treating the underlying condition, right? If it's a suspected medication causing this presentation, we want to discontinue that medication. However, we would also want to treat the patient's symptoms, particularly if it's a case of idiopathic CSVV where we don't have a known trigger. We need to give them potentially some medications or prescribe some other comfort things that we can use to help these patients until symptoms resolve. If the case is particularly severe, we would consider glucocorticoids and or glucocorticoid sparing agents. Welcome back, everybody. David here again with Med School Boot Camp. So in this next video, we are going to talk about eosinophilic granulomatosis with polyangiitis. Sometimes this is abbreviated as EGPA. Keep in mind, this is also formerly called Church-Strauss disease, but now we actually prefer to use this terminology. So this is a type of vasculitis. Specifically, this is a vasculitis that affects small vessels primarily. We've talked about this is important to keep in mind because it kind of helps us differentiate our large vessel vasculitides versus our medium versus our small vessel, just a way to kind of categorize which types of vessels or which size of vessels are more likely to be affected in the body. And so recall, a vasculitis is inflammation of the blood vessel. And as with a lot of the pathologies we've talked about in this chapter, it can actually affect a lot of different organ systems when you have generalized inflammation in the body. So first, let's dive into the epidemiology here. And you can see that this is more common in men than women, and typically going to be in that 20 to 40-year-old age range. Primarily, this is an idiopathic condition. That is to say, we don't really know why it shows up, or there's not really any strong associated risk factors, but there is some suspicion that it might be related to asthma or Montelukast or some other things, but the research for this is still ongoing. Now, when we think about our pathophysiology here, we're going to have increased T cell differentiation to Th2 cells. And remember, what is a Th2 cell versus, let's say, a Th1 cell? Well, a Th2 cell is a type of T helper cell that usually initiates the humoral immune response with B lymphocytes. These work to fight off extracellular pathogens most commonly, and one of the key players in this is actually the eosinophil. So as I say, Th2 cells can work with B cells. This can stimulate eosinophils. This can stimulate the production of IgE molecules, in addition to some other things such as basophils and mast cells. But again, the key here, I want you to remember this because eosinophils, well, eosinophilic is in the name. This is an eosinophilic condition, and this is part of the reason why. Now, what happens? Well, increased cytokine release and inhibition of eosinophil apoptosis leads to increased tissue damage. So again, we have an increased amount of eosinophils. We have inhibition of eosinophil apoptosis or destruction of those cells. And what that's going to do is going to lead to an eosinophilic condition. We'll talk about a little bit more of that in the histopathology. Now, when we talk about the presentation here, patients can present with a variety of systemic symptoms that are kind of nonspecific: fevers, chills, weight loss, night sweats, or decreased appetite. So a lot of times patients might come into an ED and the question instead might talk about patients feeling like they have a cold or the flu, right? Because there's a lot of overlap with some of these conditions that we could also see in those pathologies. Though they want you to really know that there's 3 primary phases to this actual condition. That is the prodromal phase, the eosinophilic phase, and the vasculitis phase. All 3 of these phases go together to give us EGPA, or eosinophilic granulomatosis, with polyangiitis. So first, we typically see a prodromal phase, and that's going to be an allergen-related stimulation. These can include things like an asthma attack or a case of rhinosinusitis. This is going to be followed by, further down the pathway, an eosinophilic phase, where we get GI complications. This can present as either bleeding, ischemia, perforation, or even pericarditis to the patient's tissue. So again, first off, I think about 1, what do we have? We have a stimulus, right? We have a prodromal phase. Then 2, we have an inflammatory phase, right? Pericarditis, some inflammation to the bowels that can cause GI symptoms. And then 3, we see cutaneous involvement, or the vasculitis phase. This is going to present as palpable purpura, skin nodules, mononeuritis multiplex, or posse-immune glomerulonephritis. So just as a little bit of a review, palpable purpura is a non-blanching rash of the skin. It is typically a little bit elevated, hence the name palpable, and it's kind of a reddish purplish color, hence the name purpura. These can be seen in a variety of skin findings, but it's a very classic physical exam finding in vasculitis conditions. Mononeuritis multiplex, remember, is 2 isolated polyneuropathies, or 2 different nerves are affected. And this is typically going to present as painful, asymmetric, either motor or sensory changes, and this is a pretty unique finding. And posse-immune glomerulonephritis is a type of glomerulonephritis that does not have associated deposition of immune complexes or antibodies. And so recall posse, or the word paucity, means little of or a lack of. And so posse-immune means it's lacking, or there's a little amount of antibodies that you would actually see if you looked in the biopsy of the patient's glomerulonephritis. So the key here is that this is going to get multi-system organ involvement, but it can often follow this pathway where it goes from stimulation to inflammation to ultimately tissue destruction. Now, if we move on to the diagnostics here, this is an inflammatory condition, so we're going to have elevated ESR and CRP, our inflammatory markers. We're also likely to have elevated IgE and IgG4. They really like you to know this one for test day. IgE should make sense to us, right, because this is an eosinophilic condition, but it's important to note that the IgG4 actually has more of an association with disease severity. Additionally, we're likely to see eosinophilia, and this should make sense to us. And this is going to be an MPO-ANCA or P-ANCA positive condition. And I put a high yield here because they like you to be able to differentiate your different ANCA-associated vasculitides. So you have ones that are more likely to be C-ANCA positive, some that are more likely to be P-ANCA positive, and then there's some overlap as well. But this is a very important one they want you to know as being a P-ANCA positive pathology. Now, as I always like to remind people, negative ANCA does not exclude EGPA. These ANCA tests are helpful, right? A confirmatory test is not what this ANCA test is. It's a helpful, beneficial thing that can lead us towards a diagnosis, but not all patients with this condition will have a P-ANCA. And so because of this, just because this lab comes back negative does not exclude this diagnosis. You really have to use all of the clinical picture, how the patient's presenting, all of your diagnostic tools to really make the formal diagnosis. In fact, the only way to really make the confirmatory diagnosis, which is with the histopathology, which we'll talk about in a second. Now, the imaging here, you can get a high resolution chest CT. in addition to an echocardiogram. And why does this make sense? Well, it makes sense because you want to assess these organ involvement, right? We talked about pericarditis, where we want to check the involvement of the heart. We talked about asthma exacerbation. We want to check the integrity or the structure of the lungs itself. And so that's why these imagings can be helpful. Again, not for necessarily confirmatory diagnosis, but more so to assess the level of involvement of these vital organs. Now, we talk about the histopathology here. This is the confirmatory test. And if you get a biopsy, you would see eosinophilic infiltration with surrounding fibrinoid necrosis and necrotizing vasculitis. So if you draw your attention to this image over here, you can see a blood vessel. And a lot of these small little cells in here are going to be eosinophils. And recall from our staining principles that eosinophils are typically going to stain red or pink on H&E staining. Now, when we think about the management here, it's important to keep in mind that it's going to be based a bit on disease severity. So we might need glucocorticoids and glucose-sparing agents, but again, a lot of this, including the dosage, is going to depend on the disease severity. So if the disease is not very severe, patients might just need oral prednisone with one of these other medications. However, if the disease is more severe, they might need high-dose glucocorticoids to manage their symptoms. So how might this present on a question stem? Well, the test writers could give you something along the lines of a 28-year-old patient presents to the ED with complaints of fevers, night sweats, and a new onset purplish rash in the bilateral lower extremities. The patient reports they have a history of asthma, which is managed with albuterol, but they are in otherwise good health. Vital signs are normal. On physical exam, you notice bilateral raised purplish rashes on the lower extremities, and that the patient has 3 out of 5 strength in the left lower extremity and right upper extremity. ESR and CRP are elevated. The question could then ask which of the following additional labs is most likely associated with this patient's condition. And they could give you a lot of different options here, right? They could talk about some autoimmune antibodies you might see. They could talk about some different cell lines and stuff. But the key here is that they really do want you to know this association with a PINCA. Now remember, this does not exclude EGPA if they don't have this, but commonly at this level, this is a very classic way they want to test this. And that's why I put a high yield here. This would be a very important serum lab for you to know about to help make this diagnosis for the patient. Some other things that could trip you up would be C-ANCA. We're more likely to see C-ANCA in granulomatosis with polyangiitis, which is often referred to as GPA. So they confuse you with the EGPA versus the GPA, right? EGPA more likely to have the P-ANCA versus GPA more likely to have the C-ANCA. So just a quick summary to wrap up this video. Eosinophilic granulomatosis polyangiitis, EGPA, formerly called Churg-Strauss disease, is typically going to be in a younger to middle-aged patient of primarily idiopathic etiology. Pathophysiology deals with T-cell differentiation, which stimulates eosinophils, inhibits apoptosis, and ultimately destroys the tissues. Presentation here can present with a lot of nonspecific systemic symptoms, but there's oftentimes this kind of pathway of symptoms where you go from prodromal things like an allergen-related stimulation to eosinophilic things that can cause hard GI complications, some other organs as well, to a vasculitis phase that can actually show up as the cutaneous involvement, in addition to some renal involvement and neuropathies as well. Diagnostics here, you're going to have elevated inflammatory markers, elevated IgE and IgG4, in addition to some eosinophilia, and likely a PINCA, although note, as I've said, a negative PINCA does not exclude this diagnosis. When we talk about imaging here, you're going to look at other organs that could be involved, and the histopathology is going to show the eosinophilic infiltration with necrotizing vasculitis. Management here is going to really depend on patient symptoms, right? It's going to be a combination of glucocorticoids and glucocorticoid-sparing agents, but the dosage that you need is going to be a bit more nuanced and depend on the patient's overall disease severity. Welcome back, everybody. David here again with Med School Bootcamp. So in this next video, we're going to talk about granulomatosis with polyangiitis, sometimes abbreviated as GPA. This was also formerly referred to as Wegener granulomatosis. Now, don't confuse this condition with a similar condition we talked about in a different video called eGPA, which is eosinophilic granulomatosis with polyangiitis. This is simply GPA, granulomatosis with polyangiitis, and we'll see a little bit more why that is in a minute. So remember, this is a vasculitis or inflammation of the blood vessels, and this is typically going to affect our small vessels, but can also affect our medium vessels as well. And so remember, with a lot of these vasculitis conditions, the inflammation of the blood vessels actually leads to some systemic findings. Actually, there's multi-organ involvement, and we'll talk about the key differentiating features so that you can pick this one out on a test question. So first, let's talk about the epidemiology here. And the main things I want you to know is that there's not really a predilection for males versus females here, and it's typically going to be seen in approximately a 40 to 60-year-old, so usually kind of that middle-aged patient. Again, don't get too bogged down in these. These are not hard cutoffs. It does not mean a 62-year-old cannot present with this or a 35-year-old cannot present with this. This is just an approximation. If we look at populations of people, this is kind of the average age range that would have this condition. Now, it's also important to note that this is primarily idiopathic. That is to say, we don't necessarily know what causes it. However, there is some association with URIs or upper respiratory infections. So again, GPA is typically going to affect middle-aged patients, typically going to be idiopathic, associated with some URIs, and is a type of systemic ANCA-positive vasculitis that typically affects the small and medium vessels and classically presents with affecting the kidneys, lungs, and paranasal sinuses. So, if we think about the pathophysiology here, this is going to be due to increased neutrophil expression of proteinase 3, which becomes important in a moment, and then anti-proteinase 3 antibody forms, which ultimately leads to excessive neutrophil activation and tissue damage. And as we previously said, this typically affects small and medium vessels. Now, when we think about the presentation here, as with a lot of our other vasculitis conditions, we can see a variety of systemic symptoms such as fevers, chills, weight loss, and night sweats. These are a little bit non-specific, but in general, a classic way a patient can present is with cold or flu-like symptoms, right? They've been feeling unwell for a few days or maybe a week. These in general are non-specific, but if they're paired with some of these other classic findings, that could indicate we're dealing with a vasculitis. So what are some of those other classic findings? Well, we can often have involvement of the head, eyes, ears, nose, and throat. Classically, chronic sinusitis, mastoiditis, or otitis media can present. Now, it's really important to note with these patients, they really like to test the chronic sinusitis and specifically the nasopharyngeal involvement. So we talk about having nasopharyngeal ulcers. Well, that's going to increase a patient's risk for a septal perforation. So again, this is another thing they can give you as a clue in a question stem. And the increased risk of septal perforation can lead to something called a saddle nose deformity. And so what is a saddle nose deformity? Well, if you think of a regular nose being shaped something like this, a saddle nose deformity is going to have a little bit more concaveness to it, or it's going to be shaped something like this. And so the idea being this is kind of a seat, right? You could have somebody having their legs hang off of this, right, if they're riding a horse. And so that's kind of the idea of a saddle nose deformity. So that's one of the key 3 things I need you to know for test day. The next is going to be the pulmonary involvement. Patients will classically present with cough, dyspnea, and even hemoptysis. Remember, when a patient is coughing up blood, that is very unusual. That is always pathologic, and we need to think about that and look into that a little bit deeper. One of the classic things we think about with hemoptysis is tuberculosis, but there are a lot of things that can cause hemoptysis or coughing up blood, including bronchiectasis, aspergillosis, pulmonary embolisms, mitral stenosis, but I also want you to keep this in mind, right? Keep in mind the vasculitides. If somebody presents with hemoptysis, this is also on our differential diagnosis. And the third thing is going to be the renal involvement. So this is classically going to present with posse-immune, rapidly progressive glomerulonephritis, hematuria, and red cell cast. Remember, the term posse-immune means that there is little activity of immune complex or antibody deposit in this particular type of rapidly progressive glomerulonephritis. Now, when we think about the diagnostics here, this is a commonly tested area that will get you on this question. So we need to know that serum labs are going to be positive for C-ANCA or PR3-ANCA, which is the anti-proteinase 3. Again, think about the pathophysiology here, right? We said part of this pathophysiology is that the neutrophils express proteinase 3, this increased expression. And then the body does what? It develops anti-proteinase 3 antibodies that bind to them. And we can actually see these on the serum lab. So this is a really important diagnostic clue for this particular pathology. Now, it's important to note that a lot of these patients will be ANCA positive. Approximately 3/4 of them will have this ANCA positivity, but a percentage of them might also have the p-ANCA positivity. So it's important to note that this does not necessarily tell us for sure it's this diagnosis, but it is a helpful clue. If the question stem gives you the c-ANCA positivity, this is likely helping you reach out for this diagnosis. But again, without the ANCA positivity does not rule out this, and potentially these patients can also have the other one, the p-ANCA as well. This is not a hard rule. It's rather a guideline to think of c-ANCA with this pathology. Now, important to note that urinalysis could show nephritic sediment or microscopic hematuria. So microscopic hematuria is blood that we cannot actually see on the visible eye. That would be macroscopic hematuria. And the nephritic sediment is referring to dysmorphic red blood cells, very commonly seen in a glomerulonephritis. On imaging, we can see things such as cavitating nodules. So if you draw your attention to the image over here, you can see what we're talking about. You can see some of these cavitating nodules on the chest x-ray, right? These are unusual findings. And again, this by itself does not tell us that we're dealing with GPA. It's just another clue that we're dealing with something that involves the lungs. If we combine this with something that involves the renal system, and they're having some nasopharyngeal involvement as well, right? We have our classic triad that we associate with GPA. Now, when we think about the histopathology here, this is typically going to show vasculitis, right? This is a vasculitis or inflammation of the blood vessels with a necrotizing granuloma. So you can see that granuloma right here, and you can see all the dead areas around it, right? This is a necrotizing granuloma, so that would make sense to us. One thing I do want to draw our attention to before we move on to management is to give you a quick reminder of what we mean when we talk about C-ANCA, and to do that, I want you to draw your attention over here. So remember, in P-ANCA, we're talking about perinuclear involvement, but in C-ANCA, we're talking about cytoplasmic involvement. In P-ANCA, you mostly just see the immunofluorescence on the outside, right? It's perinuclear. But in cytoplasmic, you can kind of see a little bit more of it inside the cell, right? It's a little bit more in the cytoplasm. And this is what it's talking about when it talks about C-ANCA versus P-ANCA. We're saying, is it a perinuclear pattern on immunofluorescence, or does a cytoplasmic pattern? And here in this pathology, we're more likely to see C-ANCA, although not always. So it's more likely to have a cytoplasmic appearance. Now, when we think about the management here, this is typically going to involve glucocorticoids and glucocorticoid-sparing medications such as cyclophosphamide and rituximab. There's kind of a theme here with some of these vasculitides, right? A lot of the treatment options depends on how severe the disease is. If it's not very severe, they might just need low-dose medications with glucocorticoids and maybe something like methotrexate. But as it gets more and more severe, you have to increase those dosages of glucocorticoids and consider some other medications as well. So how might they test this in a question stem? Well, potentially they could give you something along the lines of a 58-year-old patient presents to the emergency department due to an episode of coughing up blood last night. The patient reports feeling a little under the weather for the last week and has an unintentional weight loss of 10 pounds over the last 2 weeks. On physical exam, you notice some dried blood around the mouth and nares. A chest x-ray is taken showing cavitating lesions. The question could then ask which of the following is most likely to help in treating the patient's underlying condition. So this patient has a pretty classic presentation. They have the lung involvement, they have the hemoptysis, right? We have the cavitary lesions on chest x-ray, and it was noted on physical exam there was some blood in the nares. So maybe there's some ulceration going on, potentially a septal or early signs of a septal perforation. So that's 2 of the 3. The one thing the question stem didn't obviously give you was the renal portion, right? Because they expect you to recognize 3 for 3 of the symptoms. But they gave you 2 out of 3. They gave you kind of this non-specific presentation. So you can basically use your best judgment and think that at least GPA or granulomatosis with polyangiitis is on the list. So they're asking about treatment options. We're going to want to look for something that is steroid-based and potentially steroid-sparing, right? You're not going to really think about Tylenol or ibuprofen. This patient has hemoptysis. We need something a little bit more serious to address their underlying pathology. Now, before we wrap up this video, I need to contrast GPA with a very similar pathology, which is MPA, which we have a separate video about. This is microscopic polyangiitis. And you have to be able to differentiate MPA versus GPA because they can give you some of these classic findings and they're very, very similar. But there's a couple key things to differentiate these pathologies where they might talk about renal involvement and the lung involvement. But one of the key differentiating features is going to be the nasopharyngeal involvement. In MPA, there is less likely to be involvement of the nose or nasopharyngeal involvement. That is a key differentiating step. You need to see that nasopharyngeal involvement, and most questions would give it to you if they're trying to indicate GPA. If they give you just these couple of things, but they leave out the nasopharyngeal involvement, they're probably more so leading towards MPA or microscopic polyangiitis. The other key point is that MPA does not have granulomas. We talked about necrotizing granulomas here in the diagnosis, but in MPA, you would not see those things. Again, another key differentiating point between these pathologies. And then the third one that could be helpful as well, although not as helpful, is that MPA is typically going to be P-ANCA positive, or it's more likely to be. But again, there's some overlap in these conditions, right? MPA can be P-ANCA or C-ANCA. It's more likely to be P-ANCA. GPA is more likely to be C-ANCA, but it could also be P-ANCA. This is not a clearly differentiating feature, but it's another one that sometimes they will throw in there as well. But these are the 2 I really want you to be mindful of. Less likely to have nasopharyngeal involvement in MPA and no granulomas versus GPA. Much more likely to have nasopharyngeal involvement, maybe even the saddle nose deformity, and granulomas would be present. So just a quick summary to wrap up this video. We're talking about granulomatosis with polyangiitis, sometimes also called GPA, formerly called Wegener's granulomatosis. Epidemiology here, right? Typically going to be seen in a middle-aged patient and often a primarily idiopathic condition. Pathophysiology here, right? We have neutrophilic expression of proteinase 3, and then we get antibody formation against that molecule. This is ultimately going to lead to increased tissue destruction. Presentation here can present with a lot of systemic signs, but the trifecta, right? The 3 I want you to know is nasopharyngeal involvement, pulmonary involvement, and renal involvement. When we talk about the diagnostics here, the classic one they want you to know is the C-ANCA. But again, there's some overlap with other conditions as well. But this is the first one I want you to think about when it comes to test day. When we think about other diagnostics, the main one I want you to keep in mind is the cavitary lesions and the necrotizing granulomas on histopathology. Management here is going to depend on disease severity, but as it gets more and more severe, you need more and more medications, which can include things like glucocorticoids and glucocorticoid-sparing agents. Welcome back, everybody. David here again with Med School Boot Camp. So in this next video, we're going to talk about IgA vasculitis, formerly called Henoch-Schönlein purpura disease. So again, this is one of our vasculitides. It's primarily a small vessel vasculitis, which means we have inflammation of the blood vessels. And so remember, with all of our vasculitides, our vasculitis conditions, the primary overarching theme here is that we have inflammation of the blood vessels that causes multi-organ or systemic involvement, right? We are limiting our blood flow, our vascular blood flow to different organs and tissues and extremities, and this causes a variety of symptoms that a patient can present with. Additionally, it's important to keep in mind this is typically a small vessel vasculitis because we talk about our large vessel vasculitides, compare those to our medium and some of our small vessels. It helps us kind of categorize them in separate groups, although there is some overlap between ones that affect small and medium vessels or medium and large vessels. So if we think about the epidemiology here, this is typically more common to present in males than females, and usually in a younger patient population, often less than 10 years old. This is often precipitated by an upper respiratory infection, also abbreviated as a URI. This is important information to keep in mind because almost 9 out of 10 cases of this condition is going to be in a child. So when we see a question stem that says an 8-year-old presents, we need to be thinking of different pathologies. What's more likely to present in an 8-year-old versus, let's say, an 80-year-old. That's an important test-taking strategy for us to have on exam day. Now, the upper respiratory infection, right? Kids get upper respiratory infections all the time. but group A strep is the most common cause that would lead to the upper respiratory infection that could then trigger the patient to have IgA vasculitis. Now, when we think about the pathophysiology here, overall it's not very well understood, but it's likely multifactorial. It's suspected that an allergen or an infection exposure can lead to an increased production of IgA or immunoglobulin A in the body. This increased IgA can then deposit in the tissues, which can stimulate and activate the complement system. This can ultimately lead to vascular wall inflammation and damage. So remember, IgA and the complement system are important parts of our immune system. However, overactivation or overstimulation can actually destroy local tissues, and that's kind of what we see in this IgA vasculitis. Now, one key pathology I want to mention here, because it's often confused with students, is the difference between IgA vasculitis and IgA nephropathy, which is a type of glomerulonephritis. In fact, this is the most common type of glomerulonephritis in adults, and it has a lot of similar pathology where we have an overabundance of IgA, antibodies, and immune complexes that can deposit in the tissue, lead to a type 3 hypersensitivity reaction and a glomerulonephritis. So again, similar pathology, and there's overabundance of IgA, but this is a vasculitis we're dealing with versus IgA nephropathy. Remember, root word nephro means kidney. That is dealing with more so glomerulonephritis. So I want you to keep those straight in your head and not confuse those on test day. Now, when we think about the presentation here, this is classically going to present with a variety of systemic findings, which can include things like fevers, fatigues, or malaise. Again, these are kind of non-specific. Think about that this typically follows an upper respiratory infection, usually a couple weeks before patients will present with the symptoms. So as I say, they'll have the upper respiratory infection, and then maybe 1, 2, or 3 weeks later, they'll present with these symptoms of IgA vasculitis. Now, when we think about the ones that are helpful for diagnosing this condition, the classic triad is going to be arthralgias, colicky abdominal pain, that means it kind of comes and goes, it's colicky, impalpable purpura, typically in the lower extremities and the buttocks. I put high yield here, right? This is a very classic triad that they want you to know on test day. The arthralgias are usually going to be bilateral, most commonly affecting the knees and ankles. The colicky abdominal pain can sometimes be confused with appendicitis if it's in that right lower quadrant. In the palpable purpura, we see again, along with a lot of other vasculitis conditions, this is a purplish raised rash that is typically non-blanchable on the patient's extremities. Now, a few other findings they might ask you about can include intussusception, which you recall is an invagination of the proximal part of the bowel into the distal portion, right? You kind of this telescoping appearance. This is the proximal portion over here. This is the distal portion over here. And you can see it's kind of getting pushed through. This can cause abdominal pain as well. This is called intussusception. Patients can also present with melena or hematochezia, right? If there's some blood in the stools, in addition to their GI problems, and hematuria as well. Now, when we think about the diagnostics here, this is often a clinical diagnosis. So you can kind of use the patient's history, right? They had the upper respiratory infection. Now they're getting a lot of these signs and symptoms. You can use that to kind of diagnosis. But there are a couple key things they do like us to know on test day. And one of the key things is this is typically going to present with a normal platelet count. And why is that important? Because if a patient is thrombocytopenic, you need to consider alternative causes of the symptoms. This is a pretty unique thing that's important to note. HSP or IgA vasculitis typically has a normal platelet count. If thrombocytopenia is present, you need to be thinking about some other pathologies, some other conditions that might present with thrombocytopenia that can ultimately lead to rashes and purpura and things like that as well. Now, these immune complexes, right, that can deposit in different tissues can affect the kidneys as well. So patients can present with elevated BUN and creatinine. This is also a vasculitis that classically presents with ESR and CRP. And they can have decreased hemoglobin if bleeding is present. Remember, we talked about the presentation. They could have some blood in their stools. So this could present with decreased hemoglobin if it's been going on for a while, or it's a notable amount. Now, histopathology here, sometimes they will ask about, it's usually not necessary to make this diagnosis, but there are some classic findings that are very consistent with the diagnosis of IgA vasculitis. And the cutaneous histopathology is going to show things like leukocytoclastic vasculitis with IgA and C3 complex deposition. And this should make sense to us, right? This is an overactive response of IgA. If we think back to our pathophysiology here, right? Too much IgA production, what happens? Complement system is activated. Where are those things depositing? They're depositing in the tissues. Well, they deposit in the kidney. Well, we see them on the biopsy, right? We see the complement activation. We see the C3 component of the complement cascade. We see the IgA. And so this is a nice point where our pathophysiology directly relates to our diagnostic steps. Additionally, on the renal biopsy, you can see mesangial IgA deposition, C3, and fibrin, again, for similar reasons. Elevation of these substances in the body, they can then deposit in the tissues. That can either be the skin, the kidney, or other organs as well. But if you draw your attention to our image over here, you can see the skin finding, right? The leukocytoclastic vasculitis, and we've used this image before, which shows a whole bunch of neutrophils and inflammatory infiltrate resulting in a vasculitis around the tissue. Now, when we think about our management here, this is often going to be a self-limiting condition, so supportive care is needed as patients are going through the symptoms. This can include things like Tylenol, anti-inflammatories with NSAIDs. However, if patients have severe involvement, they might need systemic glucocorticoids. And severe involvement is going to involve things with very serious GI problems like bloody stools, ileus, Maybe the kidney involvement gets to be a bit excessive. They develop a bit of a nephritis. And so these can require a little bit more symptoms and potentially even hospitalization if it gets severe. But most cases are not going to be that way. Most cases are going to be treated based on symptom management and resolve on their own. So how might this present in a question stem? They could ask you something along the lines of, a 6-year-old boy presents to the pediatrician with 1 week of intermittent abdominal pain that has forced him to miss several days of school. The father reports the patient has also had a rash on both of his legs. The patient feels well overall, aside from a runny nose that began after his brother was sick last week. The parents deny any known blood in the stools. On exam, the patient is mildly tender in all abdominal quadrants. Lab values return without any significant abnormalities. The question could then ask, which of the following is the best treatment option for the patient at this time? Now, this is kind of a tricky question, but they give us a lot of clinical clues here, right? Patient had a brother or a sibling that was sick recently. They're feeling a little under the weather now. They're having this intermittent colicky abdominal pain, as well as this rash that is being described, which is likely to be the purpura, right? These are very classics of our purpuric rash, kind of these purplish raised lesions on the skin. That is very classic for a vasculitis condition. Additionally, this patient's labs are fairly normal, right? We're not given any significant abnormalities. So maybe this patient does not have a very severe condition. And so in summary, they have a triggering event. They have a recent exposure to a sick contact. Now they're getting colicky abdominal pain. They have a rash present in addition to fairly normal labs. So given the patient's age and all these symptoms, we have to be thinking about IgA vasculitis. We have to be thinking about HSP in this condition. So the question asks, which of the following is the best treatment option? Well, it sounds like this patient has a mild case. If they do indeed have this condition, it's not severe. So it's going to be symptom management. And so the answer to the question could be that the best thing to do at this time is to provide reassurance to the patient's parents. We know that mild cases of this disease is often self-limiting. And at this time, based on the presentation they give us, there's no sign that this patient is having a severe case of IgA vasculitis. So just to quickly summarize this video, IgA vasculitis, formerly called Henoch-Schönlein purpura, typically going to present in younger patients, often after a URI. This can be about 1 to 3 weeks afterwards, but again, there's a little wiggle room with that timeline. Pathophysiology here, not well understood overall, but the idea is that we think there's an allergen or infection exposure that increases production of IgA, ultimately activates complement system, and both of these things will then deposit in the tissue, which can cause vascular damage. Symptoms can be nonspecific, including fevers, fatigue, malaise, but the classic high-yield triad is the arthralgias, colicky abdominal pain, and the palpable purpura, which you can see right here on our images. Diagnostics here, often a clinical diagnosis, but some of the key labs I'd like you to know is that typically platelets will be normal. If they're thrombocytopenic, you need to be thinking about some other conditions as well. If the immune complexes deposit in the tissues, we can get a variety of findings, which can include elevated BUN and creatinine or decreased hemoglobin if the patient were to have some bleeding going on. Management here for a mild case is going to be supportive care, as this is often self-limited. If more severe things are present for the patient, it might require glucocorticoids and even hospitalization. Welcome back, everybody. David here again with Med School Boot Camp. So in this next video in our vasculitides chapter, we are going to talk about microscopic polyangiitis. And this is a really important one because we are going to contrast this with another one of our vasculitides, which is GPA, or granulomatosis with polyangiitis. We'll see that they're very similar, but there's a key differentiating feature that we need to be mindful of, because this is a common way that will try to trick us in test questions. Remember, this is a vasculitis condition, so it's going to cause inflammation in the blood vessels, specifically small blood vessels. And I remember this because microscopic is in the name. And this is kind of helpful for categorizing these versus some of our other vasculitides that can affect medium vessels or even large vessels. Now, if we turn our attention to the epidemiology here, the main things I want you to be mindful of is this is typically going to affect males more commonly than females, and it's usually in the middle age, around 50 years old. If we turn our attention to the pathophysiology here, it's important to note that this one's not as well understood as some of the other ones, but we said that it does typically affect small vessels. It's suspected that patients who have a genetic predisposition and are then exposed to an environmental trigger such as an infection or potentially a medication, this will lead them to have a reaction in the body that increases neutrophils, which bind to something called p-ANCA, and this activates an inflammatory cytokine release in the body, ultimately destroying tissues, much like a lot of our other vasculitides. Now, when we think about the presentation here, we can have some generalized systemic symptoms such as fever and malaise, but there are a lot of other multi-organ things that can occur in this pathology as well. You can have skin findings, GI findings, neurologic findings, lung findings, and renal findings as well. So let's talk about some of the common ones they like to ask about on test day. With the cutaneous findings of the skin, you get the palpable purpura. Remember, we can see this with a lot of our vasculitis conditions. You can also get something called livedo reticularis, which is kind of a lacy rash-like appearance on the skin, in addition to urticaria or ulcers. The abdominal pain can be present, much like other vasculitis conditions. Again, this has to do with the fact that we have inflammation in the vessels. You can get decreased blood flow to certain areas in the organs, and this can present in a variety of different ways. Commonly, it can be pain if a certain organ system is not getting enough blood flow or enough oxygenation. Neurologically, you can get peripheral neuropathy in the distal extremities, or this unique one called mononeuritis multiplex. Recall, mononeuritis multiplex is asymmetrical sensory or motor neuropathy that affects greater than 2 nerves in separate areas of the body. So an example could be the left sciatic nerve is affected, and then the right radial nerve is affected. These are seemingly unrelated areas in the body. They're not one local origin. These are 2 separate areas that are affected. This is an example of mononeuritis multiplex. Now, interestingly, these patients can get hemoptysis from possible alveolar hemorrhage and dyspnea, and can also experience renal findings such as posse-immune glomerulonephritis and hypertension. So what does the term posse-immune mean? Well, what it means is that we don't necessarily see immune complex or antibody deposits on immunofluorescence. So if you think of the word paucity, that means the presence of something in very small or insufficient amounts. So we think posse-immune means there's insufficient amounts or very small amounts of the antibodies that would then light up on immunofluorescence. So this is a descriptive term for the type of glomerulonephritis that these patients experience. If we jumped over to our nephrology section, we would remember that glomerulonephritis can be broken up into 3 primary causes. Type 1 is our anti-GBM glomerulonephritis that we typically see in Goodpasture disease. Type 2 is our immune complex-mediated glomerulonephritis that we can see in lupus nephritis, IgA nephropathy, and some other conditions. And then type 3 is going to be the glomerulonephritis that we typically see in vasculitis, or the posse-immune glomerulonephritis. This can be seen in this condition, microscopic polyangiitis, but it can also be seen in granulomatosis with polyangiitis or eosinophilic granulomatosis with polyangiitis as well. Now, if we turn our attention to our diagnostics here, this is really important for this condition. We can have serum labs, which are going to show elevated inflammatory markers because, again, this is a vasculitity. Typically, there's elevated inflammation in the body. You can also see a leukocytosis, increased red cells, and platelets as well. This is also often considered to be an ANCA-positive condition, that you can get a positive NPO ANCA or P ANCA in over 50% of the patients, and a positive PR3 ANCA in over 25% of patients. And just a reminder on these abbreviations, this is standing for myeloperoxidase anti-neutrophil cytoplasmic antibody, ANCA, A-N-C-A. And the PR3 ANCA, sometimes also abbreviated as C-ANCA, stands for cytoplasmic anti-neutrophil cytoplasmic antibody. And this is a type of ANCA that is primarily directed at serine protease 3, which is what the PR3 is referencing. So these patients can have either, but most commonly it's going to be that P ANCA. So if you draw your attention to this image over here, you can see that on immunofluorescence, P ANCA has the fluorescently labeled antibodies perinuclear or around the nuclei. And that's why this is called P ANCA or perinuclear, because it's relating to the pattern that we see with antibody immunofluorescence. We can compare this to some of our other conditions such as C ANCA or cytoplasmic, which would see the immunofluorescence light up more throughout the structure or in the middle. The cytoplasm would be lit up more compared to here. We see it's more so around that particular area. Now, really key point I want to mention here because they like to confuse students with this. Negative values do not rule out microscopic polyangiitis. Like I said, P ANCA or MPO ANCA is more common and can be seen in over 50% of patients. Some patients can have the C ANCA as well, but absence of this does not rule out the condition, right? These are supplemental, these are helpful things. If patients are positive for these, this can indicate that we are more likely to have this condition. But the absence by itself, because it's not 100% of patients who have positive ANCA antibodies, the absence of ANCA does not rule out the condition. And that's a really key point I want you to know so you don't get confused on test day. If they give you a classic presentation of microscopic polyangiitis, but ANCA is negative, they could still potentially have microscopic polyangiitis. Now, key point here, with all this being said, the confirmatory test is going to be the histopathology. You need to get the biopsy, which would show no granulomas. It would show neutrophilic infiltration and fibrinoid necrosis. We've talked about these previously in the chapter, but recall, a granuloma is a collection of macrophages that create giant cells that kind of wall off and have a bunch of nuclei in them. In this condition, we're saying that we would not see this, right? We would not have granulomas. This is very unique compared to some other granulomatous conditions, such as sarcoidosis, Crohn's disease, tuberculosis, but most importantly, some other vasculitides in this chapter that we talked about that would have granuloma formation include things like giant cell arteritis, Takayasu arteritis, EGPA or eosinophilic granulomatosis with polyangiitis, and GPA granulomatosis with polyangiitis. This is a key contrasting point, is that this one does not have granulomas, where a lot of the other vasculitides would have granulomas forming. Now, when we talk about the management here, these patients are often going to need immunosuppression with glucocorticoids and cyclophosphamide, and patients with severe disease may require plasmapheresis. So again, this condition is very similar to a lot of vasculitis conditions, and we have to be able to compare and contrast. We talked about the importance of the histopathology, but again, I really want to highlight, if you look at the clinical presentation here, this can be very similar to another vasculitis condition that we talk about in this chapter, and that is granulomatosis with polyangiitis, or GPA. So versus GPA, what are the key things we need to know to contrast this condition? Well, first of all, most of the symptoms are similar, but microscopic polyangiitis typically spares the upper respiratory tract, so there's usually not going to be symptoms of sinusitis or rhinitis. So again, you can get a lot of similar symptoms such as the abdominal pain, the hemoptysis, the renal involvement that you would expect to see in GPA. However, you would typically not have sinusitis or rhinitis. You would typically not have the ENT associated involvement that you would have. This is a very key contrasting point in the clinical clues that they give you about the patient's history. Also, note that MPA, or microscopic polyangiitis, is more likely to be P-ANCA positive versus GPA, which is more likely to be C-ANCA positive. Again, referring back to this does not ultimately make the decision for us or ultimately confirm or deny the diagnosis, but they're helpful pieces of information. So how might the question writers ask about this with the question stem? They could give you something along the lines of, a 53-year-old patient presents to the clinic with 5 days of fever and malaise. Patient reports a raised purplish rash in the lower extremities, in addition to intermittent abdominal pain. He reports last night he also coughed up a bit of blood-tinged sputum. The patient denies any nasal congestion or a runny nose. The blood pressure was 151/99 millimeters of mercury. When the patient checked in for the visit, serum labs show elevated inflammatory markers. The question could then ask which of the following is most likely to confirm this patient's diagnosis of microscopic polyangiitis. So this is a very frustrating question at times where they're giving you all these clinical clues, and as you're reading the question, you realize that you know what the pathology is. And then the very last line of the question, they actually tell you what the pathology is. They tell you the patient has microscopic polyangiitis. So we know right away this patient is dealing with MPA, right? Yes, we had all the clinical clues that maybe we could have determined the diagnosis, particularly talked about the high blood pressure, the abdominal pain, talked about the absence of sinusitis or a runny nose. So in our head, we were probably conferring that this was more likely MPA versus GPA. But now the question asks, which of the following tests is the best to confirm the diagnosis? It's going to give you all these different ANCA options, right? It's going to give you the C-ANCA. It's going to give you the P-ANCA. It's going to give you some inflammatory markers. But the best confirmatory test is going to be the histopathology. It's going to be the biopsy showing the absence of granulomas. Again, this is the only confirmatory test. All the other ones are supplemental in determining what this patient has, but this actually can confirm the diagnosis. So just a quick summary to wrap up this video: microscopic polyangiitis, or MPA, key contrast with GPA, a similar but different condition, is typically going to affect small vessels. It's one of our vasculitides, which causes inflammation of the vascular system. And although the pathophysiology is not well understood, it's going to be related to a genetic predisposition and trigger that leads to vascular inflammation in the body. The presentation can pretty much present anywhere in the body. You can have some systemic signs as well as skin findings, GI findings, neurologic findings, pulmonary findings, and renal findings. Again, key contrast here. The pulm findings and the kidney findings are very similar to GPA. The key differentiating feature is going to be the absence of the upper respiratory signs, and also the fact that MPA, or microscopic polyangiitis, is more likely to be P-ANCA positive versus GPA more likely to be C-ANCA. That gets into our diagnostics here. Inflammatory markers are going to be elevated. Again, this can be P-ANCA or C-ANCA positive, but it's more likely to be P-ANCA compared to GPA, which is more likely to be C-ANCA. Remember, negative values do not rule out MPA in this condition, because not all patients are going to have these positive things, but they are associations that patients might have. Management is going to come down to helping with the symptoms and really trying to create immunosuppression in the body with glucocorticoids and cyclophosphamide, and severe disease may require plasmapheresis. Welcome back, everybody. David here again with Med School Boot Camp. So in this next video, we're going to talk about something called mixed cryoglobulinemia. So mixed cryoglobulinemia, sometimes also called cryoglobulinemic vasculitis, is a type of small vessel vasculitis that is due to cryoglobulins depositing in the tissue. So what is a cryoglobulin? A cryoglobulin is typically an immunoglobulin that will precipitate at cold temperatures. This is often termed less than 37 degrees Celsius in vitro. And these can be a variety of different immunoglobulins. This could be IgM, IgA, IgG. And so that's the general idea of what a cryoglobulin is. It precipitates in colder temperatures. That's kind of the general gist of what you need to know. And so the cryoglobulins precipitating is kind of how we get to this name, mixed cryoglobulinemia. There are a variety of different cryoglobulinemias, but the mixed cryoglobulinemia that we're talking about here is typically a combination of type 2 and type 3, but we don't necessarily need to know the details of those different classes for this level. So when we think about the epidemiology here, this is most commonly associated with viral infections. This can include things like hepatitis C virus. This is one of the ones I see most commonly tested by exam writers. They also like you to know that this can be associated with autoimmune conditions and lymphoproliferative disorders as well. When we think about the pathophysiology here, this is typically going to be due to an overactive immune system, leading to mixed IgG and IgM immune complex deposition. Now, it's important to know that the pathophysiology differs slightly based on the type of cryoglobulinemia. Remember, there's several different types, which can deal with the types of immunoglobulins, their side chains, and different associated conditions. But again, I think that depth is beyond what we need to know at this level. The main thing we need to know is that when we're talking about a mixed cryoglobulinemia, we're typically talking about type 2 and type 3. As type 1 is less likely to present with a vasculitis, it's more likely to present with a hyperviscosity syndrome, which could be something like polycythemia vera or Waldenstrom macroglobulinemia. Now, when we turn our attention to the presentation here, there are going to be some systemic symptoms, right? This is kind of a recurring theme with a lot of our vasculitis conditions. We can get some general, non-specific symptoms such as fatigue and malaise, but the classic triad is going to be the arthralgias, the palpable purpura, and the weakness. Again, a lot of these conditions kind of have a classic triad. Some of them overlap, right? The arthralgias and the palpable purpura can also be seen in IgA vasculitis, but the weakness is more likely to be seen in mixed cryoglobulinemia. What's another way we can kind of differentiate these things? Well, in IgA vasculitis, it's typically in a younger patient. This is likely to be in more of a young adult or even an older patient. So again, there's a couple of key important points to compare and contrast some of these similar conditions. They also like you to know that renal disease can present and cause glomerulonephritis. Patients can also present with neurology problems such as polyneuropathy and Raynaud's phenomenon. Remember, that is when the fingers vasoconstrict, they become white with extreme temperatures or stress. And this can also have some overlap with autoimmune conditions. And so a lot of these findings by themselves are not necessarily specific, but this is kind of the best triad that we have. And you have to really look at the clinical context. What is their history, right? And then we can take it a step further and say, how do we diagnose these patients? So when we look at our diagnostics here, we're going to see these serum levels have cryoglobulinemia. This makes sense to us, right? This is a mixed cryoglobulinemia. Well, how is this going to present? We'll decrease C4 with complement activation and C4 depositing in the tissues. We're going to get decreased levels in the serum. Patients may have a positive rheumatoid factor, although not always. But rheumatoid factor is an antibody I thought was worth putting on the slide because it's actually present in a lot of these patients. Not all of them, but near all of them. A lot of these patients will have elevated rheumatoid factor levels. And this is important because when we think positive rheumatoid factor, a lot of people automatically jump to rheumatoid arthritis. This is not necessarily the case, right? Only some patients with rheumatoid arthritis have rheumatoid factor positive in the serum. It's actually associated with a lot of other conditions, even more so than it's associated with rheumatoid arthritis. Now, also important to note that these patients need to be tested for hepatitis C, right? You need to check their antibodies and see if they have this infection. Why? Just think back to the epidemiology here. This is often associated, it's most commonly associated with the hepatitis C infection. So if you suspect this condition, right, you see this kind of a rash, you see some of these findings, this is an important thing to do on their labs, right? You're checking their blood count, you're checking their chemistry panels. You need to check for hepatitis C in these patients. Now, we also need to consider that the urine can show things like RBC CAS, hematuria, and proteinuria. Remember, we talked about in the presentation that patients can get glomerulonephritis, and this would present with some of these symptoms right here. This is very common with a lot of other vasculitides where they can ultimately alter the function of several different organs, and the kidney is a very classic one. Now, when we think about the histopathology here, we're often going to see cryoglobulin deposition. Again, this should make sense to us. Leukocytoclastic vasculitis and membranoproliferative glomerulonephritis type 1. So if you draw your attention to our image up here, you can see a lot of these neutrophils that have been recruited to the area. And so this can be referred to as leukocytoclastic vasculitis. Now, when we think about the management here, we're really going to need to treat the underlying condition for these patients. Again, it gets back to the fact that patients often have an underlying viral infection. So they might need antivirals. This can include things like interferon, ribavirin, or even chemotherapy. A lot of the treatment has to do with the patient's severity of the symptoms. So it's possible that they might need additional things, including immunosuppression, depending on how symptomatic they are. Severe disease may also require plasmapheresis. So again, it may start out with just treating the underlying condition, but as cases get more and more severe, treatment becomes a little bit more intense as well. So how might they ask about this in a question stem? They might give you something along the lines of a 37-year-old patient with a history of hypertension and IV drug use presents to the clinic with generalized fatigue, joint pain, and a new onset rash on the buttocks. The patient reports some decreased sensation in their right hand as well. Physical exam is notable for raised, non-blanchable rash on the patient's buttocks bilaterally, but is otherwise unremarkable. The question could then ask which of the following tests should be ordered with the patient's lab to help make the diagnosis. So again, we kind of talked about this in the video, but a classic thing you want to do in addition to all their other labs, right, their blood, their chemistry panels, maybe a urinalysis, is you want to test for hepatitis C, right? You want to test for this with their other labs. We don't necessarily test everybody for this, but this patient has presentation that might be consistent with vasculitis, right? They have the palpable purpura, particularly on the buttocks. We know some of these classic findings they're presenting with as well. And so we need to test for HCV. In addition, the question stem also mentioned this patient was an IV drug user, which is going to have them at a higher risk of this condition as well. So just a quick summary to wrap up this video. Mixed cryoglobulinemia, typically a type 2 and type 3 cryoglobulinemia, often affecting the small vessels. most commonly associated with HCV, although other conditions can play a role as well. Pathophysiology here, overactive immune system leads to precipitation and deposition of the IgG, IgM, and immune complexes. IgA can be involved as well. Presentation here is going to be a little bit nonspecific, but the classic triad is going to be the arthralgias, palpable purpura, and weakness. Diagnostics here, we're going to have elevated cryoglobulinemia, which should make sense to us, right? Because this is a cryoglobulinemic condition. Additionally, a lot of patients, or almost all patients, are going to have a positive rheumatoid factor. Urinalysis can show some urine findings, particularly if patients are progressing to glomerulonephritis, and histopathology is going to show a very classic leukocytoclastic vasculitis with cryoglobulin deposition. Management here is going to depend on the severity of the symptoms, but in general, the first thing you want to do is treat the underlying condition. If they have an underlying HCV infection, you need to treat that with appropriate management. As the disease gets more and more severe, you might need some additional treatment options as well, which can include immunosuppression and potentially even plasmapheresis.